Okay, we are live now. Okay, you can start.
I think you start with intro and then we'll take it forward, Dr. Shubhanshu.
Manoj,
So I can start.
Yeah, Manoj, you have to start.
Yeah. So good evening, dear friends. For this Silver Jubilee of Indian Arthroplasty Association, the topic for this IA 360-degree arthroplasty webinar today is TKR in valgus knees, and we have to get on to avoiding pitfalls. Friends, we all are aware that valgus deformity gives enormous challenges, and valgus is just not the mirror image of varus knee release. There are many different techniques, but literature today lacks consensus on the structures and the sequence of release. So friends, there are many ways to enter as long as you have the same feeling at the end. So our intent today is to concentrate on planning, on approach, soft tissue balancing, and choosing the right kind of implant with tips and pearls to avoid major mishaps for the beginners who are listening this oration. So today we are going to impart potential to refine every listener to a level of finesse, like the master himself. So guys, focus on today on the practical tips, quick decision making, and plan to execute. And you see expert panels on the screen today, but remember your expert panel of masters have also failed, have turned wiser today. So now in this evening for the next 2 hours, we are going to balance the valgus knee and we have to learn to avoid pitfalls, and we'll go threadbare to learn each and every facet about valgus knee. We shall be taking forward on the Patho Anatomy of valgus, the gold standard medial parapatellar approach, anterolateral approach, subvastus approach, how to manage the bone defects in valgus, what are the tricks and pearls in femoral rotation, what do you handle first, extension or flexion gap balancing, how do you address the patellar maltracking in genu valgum, how you do lateral release, whether inside out or outside in, pie crusting or a full-fledged release or a cruciform release, how do you handle extra-articular deformities, now the newer techniques and the role of CAS robotics, or there is any space for customized jigs. We have to learn about the fixed flexion deformities with valgus and genu recurvatum, the techniques of sliding lateral condylar osteotomies. We also have to understand where we go wrong and how do we prevent the peroneal nerve. And the end of it, what kind of implant you have to choose and what is the kind of constraint you are looking in. So with all these things in mind, we have an expert panel of case presenters today. We have with us our president of IAA, Dr. Subhashish Mohanty from Mumbai, Dr. Krishna Kiran from Hyderabad, Dr. Satish from Coimbatore, Dr. Rajiv Sharma from Delhi, Dr. Ronan Roy from Kolkata, Anup Jurani from Jaipur, Dr. Rajkumar from Coimbatore, Dr. Rajesh Maniar from Mumbai, Dr. Sanjeev Jain from Mumbai, and Dr. Bharat Modi from Vadodara. I'm Dr. Manoj Wadhwa from Chandigarh, and I shall be moderating this session today. And apart from the expert master panel that we have today, we also have our keynote speaker, the master of masters, Dr. Jean Brad from France, Paris. We all have spent our times with him, and I still remember, Brad, my times with you almost close to 2 decades back when I was initially trained by Chit Ranawat, and when I came to you, it was a totally different facet of handling the valgus deformity. So we still remember the concepts, and we are very happy and very excited that during our webinar today, you are our keynote speaker. And dear friends, today to introduce our keynote speaker, Dr. Bariad, I would request our president, Dr. Subhashish Mohanty, to give an introduction about the keynote speaker.
So good evening, dear friends. Being the president of Indian Arthroplasty Association, it is my pleasure to welcome you all for this webinar. As you know, Indian Arthroplasty Association has completed 25 years. It was first in 1995. It started in 1995 and now became 2020. So we are celebrating our silver jubilee year this year. But unfortunately, because of this pandemic, that we are not able to organize our conference this year, so we have postponed our national conference, that is a IAA Con, to next year, to 2021. Now, in addition to that, we have certain other things, to show. I'll just share my screen. So this is our Silver Jubilee year, and we have now given a new face to our website. So we have a new website, that is www.indianarthroplastyassociation.com. So please go through this website and become a member of this association. We have more than nearly 600 members in our association at present. If any difficulty you find, then you can just contact over the email, that is indianarthroplasty@gmail.com, or in my personal email ID, that is drssmohanty@hotmail.com. Dear friends, I urge you to become member of this association, and those who are already members, I request you to update your address, contact numbers, and email ID through the email which I gave you earlier. Now, we are planning to organize this series of webinars on focused topic, and every weekly probably we may hold a focused topic, and the first webinar topic which has been chosen is TKR in Valgus knee. So we have named it as IA 360-degree arthroplasty webinar, where we are going to discuss from the basics till about the most difficult cases, and it will be discussion through a case-based scenario. We are planning to publish our e-newsletter at least twice a year, and our first newsletter is going to be ready maybe in a month or so. I request all of you to send your cases for publication or any other topics you like. And as I told you, our IAA Con Coimbatore is going to be in 2021, maybe September, October. We'll announce the dates later on. Now, without wasting any time, let me invite the first speaker of this webinar, that is, Dr. Jean-Louis Brad. Jean-Louis Brad is from France. May I request Dr. Brad to share your screen, please? Dr. Brad is not unknown to Indian Arthroplasty Association. Probably spends more time in India compared to France, and is an experienced, very senior arthroplasty surgeon from France, and he has an authority on doing a valgus knee as well. May I request Dr. Brad to share your screen and give his guest oration today, and what he's going to focus on. He's giving an overview of the valgus knee, going from simple to complex cases. Then one by one we'll present and discuss about nitty-gritties of the valgus knee. Dr. Brad, over to you, please. It has been a pleasure to have you here today, and thanks for devoting your time for our webinar.
So friends, Dr. Brad is going to start on genu valgum with significant extra-articular deformity, femoral and tibial. He's a senior orthopedic surgeon, as Dr. Mohanty has said, and has worked for multiple decades. He's a great teacher and friend in India. He has great interest in mobile bearing knees, computer navigation, and difficult primary and division total knee replacement. So we are waiting for you to share your screen. Yeah.
Want me to share again?
We can hear you, Dr. Brad. You have to unmute yourself.
You have to unmute yourself.
Dr. Brad, you need to unmute yourself.
Where?
Yeah, that's fine.
It's okay now?
Yeah, it's okay.
Yeah.
Can I see the slides?
Yeah, we are able to see your desktop. Now you have to open your presentation and make slideshow.
You want me to reopen this?
It's open, just you have to maximize it. You have to go to your top left-hand corner and maximize it. Press that green button.
Okay. I don't have
Yeah,
the sound here.
we are able to hear you.
Yeah, so now I need the picture.
Yeah, now you have to need the picture. You have to just click the green button on the top left-hand corner. There are 3 buttons you see, red, yellow, and green. You have to click the green button on the top left-hand corner. Are you able to do that?
I have the voice is okay, I think.
Yeah, voice is okay.
You want video? It's okay? No?
Yeah, we are not able to see the presentation completely. It shows in a small screen only.
No, Mohanty, if his internet connection is not strong enough, he can only have the audio on. He can switch off the video, and after talking, he can switch off the video, switch on the video.
I need the slides.
Are you able to open your presentation?
You want me to open again?
Yes, I think
yes, please.
Open it.
Okay.
Yeah.
Is it okay? Okay now?
It's.
I put the full picture. It's
are you
okay.
Able,
Yes.
We are not able to see the full picture.
Yeah, it's coming in now.
Yeah. Yes.
It's okay.
There we go.
Yeah.
There we go. Yes.
Okay. So hi to everybody. It's a pleasure to be with you, and especially with Jenny Valgus. So we will try to be very rational and try to take the decision according to the component of the deformity. I think it's very important. So we can have a deformity because of intraarticular reason, such as wear. I think the collateral frame can be disturbed, retraction in the concave side of stretching in the convexity. And then you have extraarticular cause, which are very important. The femur valgum is very frequent, and tibia valgum is another issue. So we want to know to make our knee well aligned, neutral, and stable. So we have to know about each component of the deformity. We have to know the pathology, understand the solution, and the consequences on alignment, stability, in extension, and flexion as well. So that's intraarticular wear. We are all aware of this, cartilage and bony. I think the soft tissues are more difficult. You can have a contracture, but such as this one, but severe retraction is seen mostly in rheumatoid disease. And you can have, this is very difficult and dangerous, elongation of the soft tissue in the convexity. We did a study of the extraarticular component in the genu valgum. So we found that you can have femur valgum and tibia, normal tibia, that is the most frequent, but you can have also only tibia valgum or a mixture of both. As we had the CT scan, we look at the both condyles. They are nearly the same size. The lateral condyle is only 2 millimeters smaller, but it's more proximal, and very frequently you have hypoplasia of the lateral trochlea. And so usually that's a usual genu valgum that we have. It's you have a normal tibia and you have a femur valgum. It's a deformity in the coronal plane, and it's usually due to metaphyseal curvature. So it's outside of the joint. You have different kinds of extraarticular deformity. You see a simple one, then stress fracture, and then tibial deformity. Tibia and femur are totally different. I think we have to be aware of the soft tissues. We know that when we have a fixed deformity, I think the posterolateral corner is very important. And here you have the arcuate ligament, which mixed with the posterior capsule. That's a very important area that we have to know for release. And then you have LCL and the popliteus. And the iliotibial band is very important, very well described by website. So we reach a classification as described by Ken Krakow. First thing, do you have medial laxity? That's a totally different knee and more difficult. But if the medial collateral ligament is good, then you can have the usual deformity with lateral contracture, bone loss, and extra-articular femoral deformity. That's type 1. Type 3, the deformity is on the tibial side, secondary to HTO or fracture, but the collateral ligaments are normal. It's really extra-articular tibial deformity. And this is a very important slide from Dick Scott. He said that lateral tightness and medial laxity are usually not a problem in flexion. That means that collateral ligaments are normal in flexion. This is also very important slide. If you have extra-articular deformity, if you want to correct this inside the joint, you have to create coronal laxity and extension. We know this in sports medicine. That's a very severe injury. You have to lengthen, release here, all the posterior capsule, cruciate, popliteus, and LCL. So that's quite a release. And we know that femoral deformity and tibial deformity are totally different. This is also very important from Krakow and website. They try to make release and then test the knee in extension and flexion. They show that if you release only the LCL, you don't get much laxity, very little in extension and in flexion as well. But if you release both LCL and popliteus, you get some correction in extension, but when you test the knee in flexion, you have a huge laxity and there is a need for constraint knee. So I think if you do lateral release, try to preserve the popliteus. What are we doing when we have a deformity, femoral deformity, extra-articular femoral, coronal deformity? Then we try to lengthen the structures on the lateral side. That's lengthen the soft tissue in extension, so you get corrected, but also in flexion. So you have to pay the price when you release to be well aligned in extension. In flexion, you pay the price. You have longer soft tissue, so you have to cheat with the rotation and you may have instability in flexion. Fortunately, we have better technique of doing release and the pike crust technique described by Insol and Ranawat is very good and it's very helpful and it's done for a medial approach. So I think this is a very important paper. So you are underneath, we are in extension, you put a laminar spreader, you are underneath the popliteus. So we will be aiming, you palpate with your finger and you will be touching and very frequently, first, the most tight structure is the posterolateral corner. So we see here, we are palpating underneath the popliteus and we can pie crust first the arcuate ligaments. And then when it's not enough, then you will palpate when it's tight, but you want to preserve the popliteus tendon. You may have to pie crust LCL and iliotibial band. And that was a great progress. Lateral approach, I think I like it because I train with Peter Keblish. It's a bit more difficult to do, but when you are used to it, it's quite good. You are fine in flexion. Remember, it's only a coronal deformity. So in flexion, you don't need any release because you have the good primary mechanics. You can perform AP cuts. And then in flexion, you have to correct the coronal deformity. So your medial extension gap should be equal to your flexion gap. And you see here, no problem. We made no release at all at this time. And but we can't extend the knee. And in order to extend the knee, you have to do lateral, sliding lateral condyle osteotomy. That will be explained later by Rajesh, I think. So you see here the fixation, it's only 2 screws, and we can correct quite significant deformity. You see here 24 degrees, it's and I use a non-constrained knee. It's just a curved plateau. Okay, now if you have medial laxity, that's very, very difficult. If you have this one, you have to use a hinge. And you have to decide if you want a fixed hinge and a rotating hinge, depending on the hip and the foot. So what's the pathology? On the lateral compartment, it's the same. And but medially, you have normal cartilage. So what is so special about the medial structures? And you remember the slide of Dick Scott saying that very often, well, no problem in flexion with the laxity. So here, when I was in 90 degrees, I try to push, I can't open. I go near to extension and that it's open up. So you have laxity between epicondyle and the meniscus. So this was addressed first by Healy, by a recession, a bone plug recession of the epicondyle. And when it's not too much of a medial laxity, I think that's a good technique. We had some very severe one. You see all the big opening here. So we correct laterally the soft tissue. We try to keep the reference with the cartilage medially, and then we correct and we augment the MCL with the semitendinosis, and we tight this on the lateral cortex. That's one way. So you have medial laxity with and without laxity at 90 degrees. If you have laxity at 90 degrees, I think you need a hinge. If you have no laxity at 90 degrees, you can use some repair. Then you have genu-valgum type 3, which happened after HTO or tibial fracture. The collateral ligaments are normal. It's a tibial extra-articular deformity. If it's minimal, pie crusting of the lateral structure is good because it has no bad consequence in flexion. But if it's significant, like this one, when you draw the tibial cut, you see you will have to remove all this bone. That's a lot. And when you excite this, you create medial laxity. So we don't want this, because if you create laxity of this amount here, you will have to augment the length of the lateral structure of this length. It's an extra-articular deformity to correct inside the joint. We don't want to do this here. So we can do intra-articular surgery, and then you correct the deformity with you redo the HTO, and then you have a stable knee, simple, no need for constraint. And look, I will show you one case like this one. This lady, when she was young, she had osteochondritis here. The surgeon did an opening wedge, and you see that she was correct. She was fine for maybe 20, 30 years. And so now he has to do a total knee, and you draw the line here, and so he did the surgery. Say, oh, I will use the PS knee because it's very stable. The cuts are perfect, but look at the medial laxity here. He say, oh, I have a problem. I should use a thicker insert. So that's what he did, but you see that it was still unstable, and then he tried to use a more constrained knee, and after a while, it was again medial laxity. So she came to me and asked if I can do something. It's simple case. That's where we start, opening wedge. So that's after surgery. We cut, the surgeon cut too much of the medial plateau, and now he has this laxity. So the way to regain the stability is to use a wedge here. So I regain my stability, but I am in valgus, so I have to do a recurrent osteotomy here, and my knee is well aligned. And now she is 15 years, and she is stable. I think I will stop here because that's a principle, and all of you will explain how to face this kind of problem, and you will detail the solutions. It's okay? Next slide.
Sounds good. Subransh, Manoj.
Yeah, I know. Are you?
You have to take over, man.
Yeah, have you finished?
Yeah.
Okay, thank you. Thank you, Dr. Brad. That was a excellent exposition of very complex cases and difficult cases, that how to handle this. Manoj, you are on. Manoj,
Unmute yourself.
unmute yourself.
Yeah, sorry. So friends, from here on, we take on to our national presenters, case presenters. And first case is going to be presented by Dr. Mohanty, our IAA president. And Dr. Mohanty, can we have your slides on the screen?
Dr. Brad, would you mind, you have
Dr.
to
Brad,
stop sharing your
You
screen.
have to stop sharing your screen. Yeah. Dr. Brad, time these slides are coming up. Dr. Brad, I have one question from you. In severe cases, grade 2, where you have a MCL lengthening or stretching, what is your preferred approach? You would like to work on with the MCL to do an imbrication or augmentation, or you would like to jump over to a constrained implant?
Well, I think now we have a classification for this medial laxity. I think that's if you have laxity at 90-degree flexion, then I think you have to use a very constrained implant. If you have no laxity at 90 degrees, so then I go in extension. I check very often when you correct laterally, it's disappear. That's what the opening that you were seeing on the X-ray is not significant. So there is no good paper about how to grade the medial laxity. So I think I check, I put tension on my lateral compartment, and sometimes you have no more medial laxity. So that's very simple. If I still have some in extension, then I will augment my medial structures. And then you can decide if you want to use a constraint or not constraint.
Wonderful. So Dr. Mohanty, you take forward, and friends, by the time we're going through, the way we're going to proceed is Dr. Mohanty will present his case, and meanwhile, if you have any questions, please move on to the chat box or Q&A section, and we'll try to incorporate after he has presented his case. So over to you, Dr. Mohanty.
Yeah, good evening, friends. I'm going to start with a very simple case, and I'm going to focus on the planning and the Patho Anatomy on the case of a valgus knee. Now, here is my case. It's a 72 years old female, and he doesn't have any comorbidities. He had a normal BMI, and he has a pain right knee for last 3 years. And this is how she was walking. As you can see the video, that how slowly the knee is going into hyperextension, and there is associated valgus as well. Now, as you can see here, the X-rays, there is a valgus of about say 20 degrees and a recurvatum deformity about 30 degrees. So how you are going to, proceed with this case comes to your clinic. Now, first and most important thing in the planning is the clinical examination. And first thing what you are going to see is whether it is a correctable valgus or a fixed valgus. So like in this picture, you see a valgus trace, and here we are giving a varus trace. As you can see here, almost the valgus deformity is correctable. And this is the hyperextension, deformity, which is there. When you lift the leg, you'll get to know. So when you see such lax knees or, hyperextension with valgus deformity, then first thing exclude, is there any congenital problems, or in our country, poliomyelitis, is there a residual poliomyelitis? So you have to ask the history and have a complete neurological examination to exclude, is there any poliomyelitis or is there any other neuromuscular disorder? If you have excluded neuromuscular disorder, then there are basically two groups of patients. One is osteoarthritis, one is a rheumatoid arthritis. Osteoarthritic patients, they usually go into hyperextension. These are lax knees. On the contrary, the rheumatoid patient, they are usually, because of inflammatory arthritis, there is associated flexion deformity as opposed to recurvatum deformity. There is flexion deformity along with the valgus. There is a possibility of post-traumatic arthritis as well. And sometimes we see many cases of post-osteotomy where they have undergone high tibial osteotomy and there is excessive valgus persisting. Those things are the last group of cases. Now, as Dr. Brad showed you that there are basically three grades or three groups of valgus knees. The first one, or grade 1, maximum number of patients we see 80%. The deformity is about less than 10 degrees. Here there are some amount of soft tissue lateral contractures, but these are correctable, but there is no elongation of the medial collateral ligament. Whereas grade 2, the valgus deformity about from 10 to 20 degrees, and these are about 15% of these patients, and associated there is lateral soft tissue contracture. Though MCL is elongated, but it is functional. Whereas the third group of patients, where is about 5% of these patients, the deformity is much more beyond 20 degrees. The lateral structures are tight here, and the medial stabilizers, they are not functional, or MCL is not functional. And as per this classification, our case, our index case is in grade 2. And next, we have to plan accordingly. So little bit about the Patho Anatomy. This is not the same patient, this is a different patient. So as I told, osteoarthritis are usually hypermobile and in hyperextension. Rheumatoids are stiff knee and there is flexion contracture. There may be associated patellofemoral joint abnormalities. As you can see in this X-ray, there is a patellar maltracking there and there is a patellofemoral joint abnormality. There is lateral femoral condyle hypoplasia, and in association with that, there is a possibility of lateral femoral condylar hypoplasia, as I showed you. And there might be a valgus tibial bow, or there's a valgus remodeling of the lower end of the femur. There is medial laxity, and complex deformities like flexion and external rotation deformities will be associated. That will gradually show you a case by case. Now coming back to our index case, after the clinical evaluation, you have to do a radiological planning. So you have to take a weight-bearing film. This is a weight-bearing film of this patient. As you can see here, there is a lateral condylar hypoplasia in the AP view as well as in the skyline view. So always take a skyline view in this group of patients. Now you draw your lines. These are the anatomical axis of the femur and anatomical axis of the tibia, as you can see here. And when you draw your line, as you can see here, the entry point of the femur is not exactly at the center, is a little medial there. So you may have to enter the femoral canal little medially. And next you decide about a tibial cut. Tibial cut is perpendicular in the coronal view. And when you cut the tibial cut, take the tibial cut, you see that minimal amount of cut is taken from the lateral condyle. And next you take your femoral cut. This is a line which is perpendicular to the anatomical axis of the femur, and you take a cut which is about say 3 to 5 degree valgus. Now how much valgus cut you have to take, it's a personal choice. I always take a 5 degree valgus cut. Some surgeons prefer in a valgus knee to take 3 degree cut. But how much valgus cut you take, depending upon that, you have to do that much amount of release on the lateral side and balance this knee. Next, to draw the axis of the femur and the tibia in the lateral view. Remember, when you cut the tibia, you should not give any amount of anterior slope in this case of where there is a hyperextension knee. So give the at least 0 degree or make me 3 degree posterior slope. But the system which I'm using that allows 7 degree of posterior slope, so I had to take 7 degree posterior slope. Next, you have to see for is there any metaphyseal remodeling, and if required, you can do a osteotomy. In this case, I do not require any metaphyseal, osteotomy. Next, you decide about how is your patella tracking. You draw this line to see that patella is slightly mal tracking, maybe laterally. Decide about the bone cuts and see that the osteophytes which are there, you have to take out those osteophytes. There are a lot of lateral osteophytes, and that completes your radiological planning. One thing you must remember, you must take a X-ray in a valgus trace. If you see medially, if your joint line is opening more than a centimeter, then probably this medial collateral ligament is not functioning well, and there you have to keep your constraint knee intact. Next, third part of planning is to select your implant, whether you are going to use a cruciate retaining or posterior substituting implant. Though I use in all my cases a posterior substituting implant, but there are certain surgeons who use cruciate retaining implant. But remember, posterior cruciate ligament is a lateral stabilizer, and it is tight in a valgus knee, so we have to release that. So in all my cases, I release it, but cruciate retainers have to balance by partially releasing the posterior cruciate ligament in a valgus knee. But if you are using cruciate retaining implant, there may be limitation in lateralizing your component, tibial component, so that the patellar tracking will be adequate. Hence, that is a limitation about cruciate retaining implant. And number two, if the patient has got a plano-valgus, foot, and if the tibial is posterior is not functional, then be aware to use the cruciate retaining implant, because that may fail in these kind of cases. So if you see a plano-valgus foot associated, the better to go for a posterior stabilizing implant. You can keep your constant implant always ready on the table, either a TC3 or a CCK, or hinge knees also you may keep on the table, lest your medial collateral ligament are non-functional like grade 3 knees, or intraoperatively you may do some injury to the medial collateral ligament. Now, intraoperatively, in this case, what we did, we went by medial parapatellar approach. You can go by lateral approach, which has been described in the later part. Some of the speaker is going to describe in detail if there is severe valgus knee. In this particular patient, I found some cheesy material that that white cheesy material may be due to steroid injection, which is there before, has been injected before. The ACL, PCL both are lax and degenerated, so I had to excise both of them. And in the beginning of the surgery, take out all these lateral osteophytes, which I took out in the beginning of the surgery. Then femur, I took a standard cut of 5 degree into 9 mm, whereas on the tibial side, I took only a 4 mm of medial tibial cut with a 7 degree slope. So you have to take a very less tibial cut in this lax knees. Pie crusting of the posterolateral corner and IT band was done with a 18 gauge needle. Normally, Dr. Ranawat recommends with a 15 number or 11 number blade, but preferably one should do with 18 gauge needle, because that is helpful, that gradually you can do. There was a content defect in the lateral posterolateral corner of the tibia, and on the femur there was a hard bone, hardly we took any cut, so we have to make multiple drill holes and fill up it with the cement. And post-operatively, we left the knee about 10 degrees of fixed flexion deformity, which eventually stretches out. So in lax knees, please do not achieve a complete correction. You have to leave little bit of flexion deformity, which eventually corrects out. This is the post-operative X-ray of the patient. We got away with the primary implants. That is the 7 years follow-up of this patient. As you can see here, the valgus thing is corrected, the hyperextension is corrected, and that is the amount of movements. There is no extension lag, and the patient who was walking like this pre-operatively could have a normal gait after the surgery. So this is his gait before surgery, this is the gait after the surgery. So to conclude, dear friends, the take-home message is that valgus knee is about 10 to 15%, and usually in elderly ladies. There is associated lateral femoral condylar hypoplasia, valgus tibial bow, medial laxity, and there is associated patellofemoral disease. Avoid excess bone restriction from the beginning, especially in a valgus hyperextension knee. In the planning, you must have an adequate clinical examination to see that whether the valgus is correctable or fixed valgus. See the radiological planning, see the lateral condylar hypoplasia, see the patellar maltracking, and you have to implant selection, whether to go for a constraint knee or a hinge knee. That depends how you have planned, and on the table how you achieve the ligament balancing, and of course the complex deformities like osteotomy, post-osteotomy cases, ligament advancing, etc., which will be shown by the other speakers. I thank you for a patient hearing. Is there any question? In the meantime, I request the next speaker to share the screen. I'll stop sharing my screen.
Wonderful, Dr. Mohanty. By the time we get questions from another panel, let me put it forward. For your radiological assessment, you showed on the weight-bearing AP, lateral, and skyline views. Do you feel there is need for long leg X-rays?
Usually, if there is no associated deformity, extra-articular deformity, I don't take a long leg X-rays, but you can take a long leg X-rays if there is associated hip replacement or extra-articular deformities. Then better to take long leg X-rays so that you can decide about your alignment.
Manoj.
Yeah.
I have a question for Subhranshu as well as the rest of the panelists. Normally, I mean, a hyperextension of the type we saw in the pre-op gait is usually not just a matter of just simple bone loss. That type of hyperextension is usually associated with some type of a neurological background issue. Might not be polio, but some neurological component. And in this case, it's a 7-year follow-up. So Subhranshu and the patient both have got away with the initial stability that he found on table. But would some of the panel members comment? Because my experience is that in a hyperextension knee, even if you get it on table, as time passes by, it might actually recur again. And therefore, wisdom might be in going for a constrained implant to begin with, like a hinge knee or something. Any comments on this?
Dr. Mohanty, I think starting.
That's a good thing that we keep always constant implants standby on the table. But once preoperatively, if you have evaluated,
just a moment. It's not a question of having an implant on table. It's a question of deciding whether in times to come, your non-hinge implant will still be able to hold that hyperextension from becoming further once again recurring as a result of a background neuropathic element, because hyperextension does not all that frequently happen just from bone loss. In varus knee, you have huge bone loss.
I agree.
So hyperextension is something that is a very different type of a problem. It's not just a bone loss problem. So I'm just trying to get an opinion, because I've had this experience in the past, where on table it looked to be good because I filled it up, and yet it would deteriorate as time passes by.
Yeah, neurologically, if you have examined the patient and if you have seen there is no other neurological problems associated, especially you can see the if there is no plano valgus fit and other neurological examination is normal, then I go ahead with a normal standard PS implant. But your point is very well taken, that in a severe hyperextension like that, you all maybe preferably may use a hinge knee. But
do you need to step in?
Then you do not have any other knee standby. If suppose the hinge knee fails tomorrow, then you don't have anything in your hand.
Rajesh, you need to unmute yourself.
Dr. Brad was
if I could give a small comment, Manoj.
Yeah.
The cases where you have the posterior capsule is not stretched, not overstretched, and posterior capsule is on the table, you feel that posterior capsule is not overstretched. These cases probably you can go ahead with the normal implants and not the constrained implants. If you feel that the capsule is stretched excessively, then probably the only way is the constrained implant, as Bharat is saying rightly.
I think what Bharat is trying to say is that we normally would just move on with less amount of distal femoral cut to bypass these things and use a normal PS. What he's trying to say is that his experience in the past is that a couple of cases do stretch up more as time procures on, and should we be considering to use a constraint implant in the beginning?
No,
Yeah,
but
Rajesh.
if you get residual FFT of flexion deformity of 10 to 15 degrees, as Shubhranshu did in this case, how many of you would feel comfortable with that? I mean, would that be adequate in the medium to long term?
Yeah, Rajesh.
Yeah, I think I wanted to make the same point as Bharat, because that much amount of hyperextension would worry me. And I think what Rajiv was saying is right. How would you know that the posterior capsule is stretched or not? Whichever hyperextension, it will stretch, but it's the anterior part of the tibia or femur. If there is a bony compression sort of, probably it is osteoarthritic. And I think that much amount of hyperextension, one really needs to worry. Although in this particular case, in the post-operative stretching for 7 years has not occurred. It has not gone back into hyperextension. So probably it was not a neurology. But I think that much amount of hyperextension, I would always be worried that there is some neurological component. I agree with Bharat on that.
Yeah. Raj, you can continue. Raj, you need to unmute yourself. Rajkumar, you need to unmute.
Just
Is Krishna Kiran's
2 points quickly. One is, even if we keep 5 degrees or 10 degrees of hyperextension flexion in this case deliberately, there is a high chance it might progress to hyperextension post-operatively. Maybe in this case, it does not happen. Maybe on table, it is difficult to gauge which case to do a constraint or not. Sometimes it becomes very difficult to decide on table. But the one more point we can take it is, under anesthesia, we can again check before incision what kind of hyperextension it is, still more it is going. If it is going more than what preoperatively it is there, very abnormally, then we have to have a constraint hinge processes as a backup. So that can give us an idea that it can progress very easily.
As I told, in my presentation, at the end of it, I left it around say 10 degrees of flexion deformity rather than full correction. So probably that might help. If you have to live with some amount of little 10 to 15 degree of flexion deformity.
Wonderful, Dr. Mahanti. I think from here on, we will move on to the second speaker, and we will just on the message that you've given your slide. It's basically to work onto the planning to see whether your deformity is correctable or it is fixed. The role of stress test, whenever you have a recurvatum, to sort of check on the neurological examination, the runabout grading, the radiological assessment, and an optimal implant selection. And for any recurvatum, the availability of constrained implants on table. So now with this on, we move to Dr. Krishna Kiran for his second presentation.
Yeah, good evening. I'm going to talk about computer-assisted cruciate retaining knee feasibility with a subvastus approach and lateral partial condylar slide in a valgus situation. So the PCL attached on the posterior medial aspect of the femur, and we've heard from Dr. Bryant that the flexion space is reasonably okay in most of the situation, and it is more of a extension problem. And if you do too much of releases, then the flexion gap may become too high and then may be associated with instability. And PCL is also a secondary stabilizer on the medial side for flexion. So we all know that PCL is tight in flexion. And it has been our practice to do cruciate retaining knees with CAS in most of the situations. And I wanted to see if it is applicable for valgus, and we've been doing this for the past 10 years. So I'll take you through a case which hopefully illustrates the principles behind this thought process. So we have a 56-year-old lady here with bilateral knee pain with left side more than the right, with difficulties of activities of daily living. So this is a 20-degree valgus deformity, and this is the sort of plan we make preoperatively. The aim is to get bone cuts perpendicular to the mechanical axis if we are doing mechanical alignment, and we will usually be ending up with some sort of tightness on the lateral side, and the medial gap seems to be okay or sometimes slightly higher. So the idea is to release the tight lateral structures to equalize them to the medial side and get a rectangular gap throughout flexion and extension and restore the mechanical axis, whether it's a valgus or a varus knee. Now, this particular thing will look at the role of subvastus approach, role of CAS, prerequisites for cruciate retaining implant, and what is the indication for lateral partial condylar slide in our thought process. And there is some limited literature on most of these. And Whiteside in 1999 published on good results with cruciate retaining knee with selective ligament release based on whether it is tight in extension or whether it is tight throughout the range of motion. And he suggested that we must preserve the LCL and popliteus in order to do a cruciate retaining knee replacement. So what we look at preoperatively is the Su classification, whether the MCL is stretched out or not stretched out. So the patients where the MCL is not stretched out with a correctable or a partially correctable deformity, all of them will get a cruciate retaining knee replacement. In those patients where the MCL is preoperatively stretched out, it will depend upon the intraoperative situation, whether we are able to balance the knee with a plastic less than 14 millimeter or not. If the plastic thickness is having to be more than 14 millimeters to balance the knee, then probably we will increase the level of constraint intraoperatively. So the role of subvastus approach, people would think it is counterintuitive because we have a lateral sided pathology. And why would you want to do a subvastus approach in these patients? And everybody talks about instability following valgus knees and what would be the role of cruciate retention. So if we are doing a medial parapatellar approach and for some reason we would have to do a lateral retinacular release for patellar tracking, then there is definite issue of vascularity of the patella. The subvastus approach is counterintuitively actually more easy to do in a valgus knee because the medial side is stretched out and patella more or less is subluxated out onto the lateral side, and that's what we do with the subvastus approach, and it preserves the patellar vascularity. In the event we require a lateral retinacular release for adequate patellar tracking, there is of course potential for early recovery, but the cons of this approach are there is risk for inadequate exposure for lateral release, malalignment. So if you combine it with CAS and don't do any sort of lateral release and do the release through the lateral partial condylar osteotomy, then you will offset some of the problems of the particular exposure. While cruciate retention is possible in patients with no medial laxity, retention of LCL and popliteus are prerequisite to avoid late instability. The bone conserving easier cruciate retaining knee makes it easier to fix the PLCO where needed, and there is less risk of condylar fracture. So we will look at some of these steps. So this is not a valgus knee or the same knee which I'm showing, but I'm just illustrating some points of the subvastus approach, which usually is like this. We identify the VMO insertion onto the patella. And there are three types of insertion where there is a high insertion, intermediate and low insertion. And we do an L sort of capsulotomy and just subluxate the patella out of the way. The initial arthrotomy is done in flexion of 90 degrees, where we remove the, we do the L capsulotomy. And then the inferior part of the operation is similar to that of a standard medial parapatellar approach. So one additional step for a medial subvastus approach is to identify the synovial tether and release it. And once you release the synovial tether between the VMO and the vastus medialis obliquus, you will be able to automatically be able to subluxate the VMO out of the way. And usually you'll be able to see adequately for your total knee replacement. So this particular case we did with CAS, we identified that the valgus deformity in extension was around 19 degrees. And at 90 degrees flexion was 5 degrees. So the deformity is not that much in flexion as was previously discussed. And you look at the problem is predominantly in the distal femur. So 11 degrees of distal femoral valgus as compared to the mechanical axis. And the femoral rotation was set at 5 degrees. And Dr. Mohanty rightly said, we must take limited amount of tibial cut in these cases in order to compensate for a lax situation which might arise later on. So 3 millimeters from the medial side was removed and at a 7-degree posterior slope as is done normally for cruciate retaining knees. So when do you choose to do a lateral partial condylar slide? So this is again controversial. So there are takers for kinematic alignment who say that you must correct the knee to whatever would have been the natural alignment for that knee. But what we follow is a restricted kinematic alignment. So if it is within plus or minus 3 degrees of neutral, then we would not do any sort of soft tissue release. But if the deformity is between 3 and 6, say, then we would probably accept it. But if it's 6 degrees of more of deformity after the trial reduction, so you do the measured resection of the femur, you set your femoral rotation, do the tibial cut, and do a trial reduction after the posterolateral capsule and ITB release from the Gerdy's tubercle. And if the residual alignment is 6 degrees of more or more of valgus, that would call for something in my book to balance that particular knee. So in this particular case, we did a partial lateral condylar osteotomy. And it is a relatively simple technique where you take 1/4 of the condyle, take a saw and just take it off. And as we remember rightly, the posterolateral corner along with the popliteus and the lateral collateral ligament constitutes a single structure which is attached to the lateral epicondyle and slightly anterior to it. By removing this particular structure and mobilizing it distally and posteriorly, we are able to correct the deformity both in extension as well as flexion. So this is the intraoperative picture. Typically, there will be some amount of overlap with the trial components on, which needs to be trimmed, and this large surface area makes it relatively easy to fix. And the picture on the right, you can see that with the subvastus approach, you can see nicely the patellar tracking on the center of the femoral component, and it is uncommon for us to do a lateral retinacular release. And this is the post-implantation image showing correction to 2 degrees valgus in extension and 0 degrees in flexion. And that is a post-operative X-ray where we have managed to deal with this type 2 valgus situation with a relatively less constrained option and a partial lateral condylar osteotomy using a subvastus approach. And there is no change in the postoperative rehabilitation for these patients. The take-home message, the subvastus approach is possible for valgus knees. It has got potential for faster rehab. One must look at the patellar tracking and patellar vascularity as additional advantages of this approach. Maybe technically easier to do a subvastus approach because of some sort of medial stretching, which inherently happens in a valgus knee. CAS will ensure the accuracy of bone cuts and a real-time monitoring of the deformity. You can do cruciate retaining knee, not just for doing cruciate retaining, but it is possible because it's a secondary valgus stabilizer on the medial side in flexion. And when you do a cruciate retaining knee, it is reasonable to do a partial lateral condylar osteotomy as opposed to all these complex releases. And since the release happens not at the joint line level, the risk of peroneal nerve injury in our own experience is very, very low. The patients where the medial collateral is stretched out, you could still do a subvastus approach and CAS and a partial lateral condylar osteotomy, but you may have to be prepared to increase the level of constraint in these cases. Thank you.
Nice, Krishna. By the time my friends get on with the questions, I have one thing to, I'm myself a CR user, but a couple of guys who love the PS needs for all these valgus deformities, they have a reasoning that PS design allows you femoral lateralization. That means you have less chances of lateral release. What is your viewpoint over there?
So my personal experience with the subvastus, all these are combination factors, right? You have to do the subvastus approach, then you do the correction through the partial lateral condylar osteotomy. If you require a lateral retinacular release, you can do it much more safely. Sometimes it is required, so you will do it much more safely because you're not going to devascularize the patella.
Anuj.
Yeah.
But Krishna something.
Yeah.
See, and this is actually the heart of valgus knee as a topic. That, in fact, when you review the literature about the sequence of releases, that have the order in which the lateral side release have been advocated by giants of our world. And in my case presentation, I'm going to sort of summarize this. And this is classic. Krishna went for what otherwise would be considered as a significant step in the form of that partial lateral condylar osteotomy. I am asking him, why did he not do a simple pike resting of the lateral iliotibial band, and he could have got that 6 degree or a slightly more valgus corrected, which is a far safer procedure to do. And I don't question
that is the same question is on the YouTube also.
After the resting was done, after the there is no doubt on that. The iliotibial band is released first, whether reversible or pike resting. I am saying you should not release the lateral collateral ligament and popliteus.
Okay, so you did release the iliotibial, and then that was not clearly sort of we missed it.
That the posterolateral capsule and the ITB were released after removing the osteophytes. And if you do a trial at that stage and you see 6 degrees of valgus residual, there are I would not accept it. So if it were showing 3 degrees of valgus, I would probably accept it and then go away. But if it's 6 degrees or 7 degrees, then at that stage I would do a partial lateral condylar osteotomy.
Fair enough. So you have made your point that you would do the simpler releases first, and then failing which you would do that. Fair enough. I mean that.
Yeah, that Rajesh and then Raj to continue. First, Rajesh.
Krishna, did you mention that you avoid having to do the lateral retinacular release for the tracking because you've done the lateral epicondylar osteotomy?
No.
Because that in no way is going to correct your patellar maltracking if it is going to happen.
No, not at all. So I don't, I'm not saying that. What I'm saying is, a lot of the times there is a visual impression that the patella is maltracking because you do a medial parapatellar approach. And our own incidence of lateral retinacular release is so low. And we do these skyline views and see the thing. It appears that the patella is maltracking. Sure, if there's maltracking after the subvastus approach, we would do an release like you've described. So we would do a lateral retinacular release with much more confidence that nothing will happen to the vascularity. So I'm not
exactly. I think lateral epicondylar osteotomy has nothing to do with the patellar tracking.
Yeah, Raj, you can
nothing to do with.
Manoj, there are certain questions from the YouTube. I think we should take up.
I think first let Dr. Raj ask, and then we take up the questions. You take it forward from there.
Yeah, Kiran, that was good. The only thing is, even in this regular, unlike without doing a subvastus or a cast, even in a type 2 valgus like this, you don't need to release the popliteus at all. Even without that, you can achieve the correction. So the popliteus release should not be the indication for avoiding a popliteal release should not be an indication for a subvastus or a cast. So even without a popliteus release, we could have achieved a correction in this kind of type 2.
I would agree with you. A lot of the time you're not doing cast. So people who do cast regularly, you cannot recognize the 6-degree valgus. Probably if I was not doing cast 10 years back, I would accept that 6 degrees because you can't predict that 6 degrees or 5 degrees. So this technique is specific to use of technology. You cannot do lateral epicondylar osteotomy or something XYZ without having a measurable guide to what is the alignment intraoperatively. So that is the thing. So all are not exchangeable. They're all interdependent. So the approach, the cast, the osteotomy, and the need for lateral retinacular release they're interdependent. They're not exclusive of each other. So you would not go and do a lateral epicondylar osteotomy or something like that without having technology. That's
Krishna, you have given a cocktail, so that's why everybody is confused. Yes, Dr. Mohanty.
Yeah, there is a question for Dr. Brad from Dr. Indrajit Sardar that when you do popliteus release?
Dr. Brad, when do you do your popliteal release?
Well, I don't touch the popliteus because I think I will think that you have some play with the popliteus. So you can release, if needed, the LCL, but keep the popliteus. I think we release the popliteus in varus knees, but not in valgus knees. When I do a sliding osteotomy, well, you can say that I release everything laterally. But I think that's when you do a sliding osteotomy, it's because you have some extra-articular deformity and you correct inside the joint. And the good thing about sliding osteotomy is that you keep your ligaments strong and you can balance even if you keep PCL. I think in the cruciate retaining, I think the reason why to do a sliding osteotomy is because you have 3 structures to balance: medial, PCL, and lateral. And if you correct any extra-articular deformity, then it is impossible to balance the 3. So that's why I think Dr. Krishna is doing some osteotomy. He is correcting some extra-articular deformity inside the joint and then can balance the 3 structures.
Good. Dr. Satish, can you just put up your slides in the meanwhile? Can you put up your slides?
I just want to ask a question to Kiran.
That is a good thing, that popliteus that you try to preserve in the valgus knee because that's a good lateral stabilizer. Now, next question from Dr. Devabrata is that Krishna, could release only posterolateral corner would have been enough rather than an osteotomy? I think we have discussed this.
We have discussed this part.
Dr. Anupam Srivastav, how you see patella change in valgus knee is more meaningful than a varus knee. Dr. Krishna, can you take up this question?
What was the question?
How you see patella change in a valgus knee is more meaningful rather than varus knee.
So patella resurfacing in a valgus knee, is it more meaningful than in a varus knee?
Yeah.
Okay, so as a principle, I don't resurface any of my patella. So I just remove the osteophytes and do a patellar rim cautery. That's what.
So let me add up to that. If you're doing a patella resurfacing and you realize that in a valgus knee you have a lot of maltracking, you have an option to use one size lower and medialize that patella for a better tracking, if that takes up as a question. So now moving on to the next, Dr.
Last
Satish.
question. Just
okay.
one more question from East Coast Ortho. Dr. Brad said that valgus knees can be from tight structures above or below the meniscus. Could you please elaborate? Dr. Brad, please.
Well, I think, well, so we are speaking of medial laxity. And I really found when I check my medial compartment, I'm very surprised. Nobody can explain this. You have most of the knees, except the wide open, you have no laxity at 90 degrees. So I do my meniscectomy, but I put some blue on it, and then I look through range of motion. When I am in extension or flexion, and then it's open up. So there is something we can't, nobody explain. Why do you have laxity at near to extension, and why don't you have laxity 90 degrees? But it's helped me to decide which kind of knee I should use. But
okay.
Yeah.
If you have the explanation why, many people will buy it in the world.
Dr. Satish, you start sharing your screen, and in the meanwhile, let me give an introduction to your talk. So Dr. Satish is going to tell you that when you want to drive a car, you can enter from the opposite side too, but the best is where the steering wheel is. So he's going to explain you on the lateral approach for handling a valgus deformity.
Thank you and good evening all. And this is a patient, 65 years old male patient.
So we can't see your screen. We can't see your screen.
We can't see the presentation.
Well, no patellar complication with lateral approach.
Yeah, it's there. It's there now.
Can you see now?
Yeah, it's there.
Yeah. So this patient is 65 years old male patient. He has got knee pain for around 12 to 15 years. Deformities around 5 years. Difficulty in walking for the past 1 year. And he has got severe varus on right side and valgus on the left side.
Dr. Satish, can you take your microphone a little closer? You have to be a little louder.
Yeah. Yeah. But despite this deformity, I think he was able to walk. The X-ray, this X-ray shows the X-ray test is just taken in lying posture, and this is the X-ray which shows after giving some traction. Obviously, a lot of instability is there. With traction, the deformity is a lot of deformity is corrected. And also, we can see both on the medial side and the lateral side, there is a defect in the tibia. There's a medial defect on the varus side, and there is a lateral defect on the valgus side. So closer view shows a very clear defect. So the Patho Anatomy of the valgus knee has to be understood, everyone should understand before venturing into a knee, as been already explained. I'd just like to say that the lateral femoral condyle is small dysplastic, especially on the posterolateral side, but also the tibia can be dysplastic. Apart from the three diagnostic categories of rheumatoid, osteoarthritic, and post-traumatic, we have to add the entire distal femur has not formed properly, and the remodeling is very poor. So there is increased skew angle, extension of distal femur, and secondary remodeling. All those things has been seen in the pre-operative. The soft tissue pathology, all of us have already seen the medial tissues are lax, laterally the tissues are tight, and according to me, in a valgus knee, the lateral retinaculum is a tight structure to start with. And these are various contractile structures. The extension gap is generally contributed by IT band and postlateral capsule. Lateral clavicle ligament and tendon of esophagus can contribute to both flexion gap and extension gap. Can contribute. So we have to distinguish between the fixed part and the flexible part in any deformity. In a valgus knee, the flexible part is contributed by medial soft tissue laxity, lateral bone loss, it can be femoral side and the tibial side, and the fixed part is contributed by lateral retinaculum, ITB, and all the other structures what we have shown here. The surgical classification is the one which guides us how to go about the surgery. The clinical valgus is the weight-bearing valgus. The patient is standing, how much angle you see. That is the clinical valgus. To make the patient to lie down and give a varus strain on extended knee. How much is the residual valgus? That is termed as clinical fixed valgus. Now, if you do the same thing in the operating room, after eliminating all the pain, you stretch, you give a varus stress, and now see what is the residual valgus. This residual valgus is what I call it the surgical valgus or true valgus. This determines the degree of lateral soft tissue contraction that requires release for the decompensation. So a person who has got a clinical valgus of 25 degrees can have a surgical valgus of 0 degrees or 25 degrees based on a combination of what are the factors are involved. So when we should go for a lateral perpendicular approach? In my books, it is the surgical valgus is more than 5 to 10 degrees. There is a documented preoperative patellar maltracking, dysplastic type of valgus deformity, posterolateral bone defects, valgus associated with flexion deformity or less flexion, it's a stiff knee. Why? Compared to the medial approach, lateral perpendicular approach is a direct approach. The tight lateral tissues are properly visualized. Titrated sequential release can be done. Better deformity correction, better balancing can be done, and there is nothing called a patellar maltracking, and it can be applied to all grades of deformity. Lateral perpendicular approach is not simply lateral arthrotomy. The 4 steps involved are coronal laseroplasty of the lateral scapula, quadriceps snip, and then gap balancing, and then closure of lateral prosthetic joint. So this was described first in 1985 by Dr. Blish, and subsequently we modified it. That's what I do. And the first step, after giving a midline incision slightly on the lateral side, 90 degrees, you flex the knee and give a midline incision just on the lateral one-third of the patella, centering lateral one-third of the patella. And you have to elevate skin flap on the lateral side only. Immediately, you are not going to elevate any flap. Now, after elevating the skin and subcutaneous tissue, you consider the lateral retinaculum capsule complex as 2 layers. We are going to divide it into one anterior layer and posterior layer. How we do that? You mark a incision 2 to 5 centimeter lateral. This is the lateral border of the patella, lateral to the lateral border of patella, and then start doing undermine dissection. The anterior flap should be in continuity with the patella, and the posterior flap should be released from the patellar lateral margin. So I will show a short video. Can you see the video? Hello?
We can see.
Yes, sir. So this is the head end, and this is the foot end. You can see the foot. So the anatomic dissection is done, and you can see on the deeper side, the joint is open close to the lateral margin of the patella. Now the joint is getting open on the innermost side. The joint is open now. So we have got anterior flap, which is in continuity with the anterior aspect of the patella. So you continue the dissection downwards. When you continue the dissection downwards, we take all the retropatellar and fat, which is behind the patellar ligament. You take it along with that sleeve and take portions of meniscus also. Cut the meniscus, lateral meniscus, anterior aspect, and take one portion of that also. So everything has to be retained. And as a continuity downwards, we release the iliotibial band. So you can see here the fat pad and the meniscus, everything is there, and we are releasing the iliotibial band. So this is the pictorial representation of that. And the dissection has to be superiorly extended along the lateral edge of the quadriceps tendon. And inferiorly, the iliotibial band is released, and the capsule which is adherent to the osteophytes are all released. So this lateral flap will have all the structures. And the next step is to do a quadriceps snip. Generally, it is required in most of the cases. and then the patella is everted and the joint is exposed. The menisci are removed, ACL, both ACL and PCL are excised. We have to do a reverse intra-nerve maneuver. That is, we put a bone lever behind here and then internally rotate. The leg is internally rotated and the knee is hyperflexed. Now this will deliver the pathological posterolateral corner on the view with excellent visualization. Otherwise, this portion is generally hard to see even in a varus. To see that in a valgus knee, I think it is very difficult form. So here we can see that very clearly. Then remove the osteophytes, and the next step is the bone cuts and balancing. You have to have a little bit orientation when you use all the jigs, because this is the right knee, the patella is here, and we are open from the lateral side. So the jig should be accordingly. You have to take the left side jig so that we can cut. And the normal condyles has to be taken as reference. And we have to achieve the gap balance, and generally by these two steps means after releasing the IT band, and we see the gap, the extension gap is still trapezoidal on the lateral side, we have to release the posterolateral capsule. And after that, most of the cases will have a good rectangular gap. Only extreme cases, if we feel that still tightness is persisting on the posterolateral side, especially at the tendon of popliteus or LCL, we may have to release them. So the last step will be the quadriceps snip repair, and then you can see the stability of the snip repair at 90-degree flexion. And you need not worry about anything. The patella will just the patella will sleep, hugging the patella femoral component, and then close the lateral side. And this is the margin, one margin, this is another margin. So we have done what is called expansile lateral arthrotomy. If you have done a single arthrotomy, like you do lateral retinocular release from the medial side, if you do like a single incision, this area will be having a gap. Now, because it is we have done it in an expansile arthrotomy, what you call coronal Ezepian arthrotomy, we can close them. And we used to give this patient hinge knee braces for 6 weeks to avoid inadvertent sudden knee flexion, because the quadriceps snip repair has been done. But most of the patients can walk on the first or second day. So this particular patient, you can see there is a very clear big posterolateral defect. So bone grafting has been done, and you can see the layer, and it has been closed. And again, that is the what we call the expanded area. And the skin can be closed. This is the immediate post-op X-ray. So the video is not working. So this is the 5 years post-op. You can see the graphs are interpreted well. So in conclusion, the valgus and varus, these are the two deformities which have diametrically opposite components. So trying to approach both by a medial approach may not be appropriate. If the deformity is less and if it is flexible, less than 20 degrees, definitely most of the medial approach will be very good. If the surgical valgus is more than 5 degrees, generally I prefer lateral approach. You can see the tight structures laterally easily, and it can correct it under vision, and it gives a better deformity correction and excellent patellofemoral balance. So if somebody wants this, I think this is available. We have published this in the JBJ's surgical technique, or we can contact me. Thank you.
Thank you, Dr. Satish. So by the time your talk is open for discussions, can you just stop sharing so that our next speaker, President-elect, Dr. R.K. Sharma, can put up his slides? So any questions for Dr. Satish or Dr. Rajesh? You have to unmute yourself, Rajesh. Dr. Maniar, you need to unmute yourself.
Yeah. Can you hear me now? Yeah,
yeah, so we can hear you.
I think the question is that doing a quadriceps snip to do a primary total knee, does the panel feel that this is a little bit more to do to get that lateral view? That is first question. And the second question is that, tell me, how did you close that extensive arthrotomy which is opened on the lateral side? You've not put the two retinaculum back together. So that is the biggest problem, closing that large gap that you have there.
The second question I will answer. The second, you can already shown you, because this is expanded arthrotomy. There are two layers. So we think of lengthening. It is a lengthening. We have lengthened the tissues on the lateral side. In fact, this procedure has been copied from lateral pressure syndrome, where they do the same thing to release the pressure on the lateral side rather than simply doing a lateral release. So there are two layers. Both the xray cases, what I have told, you would have seen that there is absolutely no gap. In fact, the gap will be there only when you approach from the medial side and to do a total lateral release. The full retinal, there will be gap on the lateral side. The gap will never happen.
You can leave the synovium intact, which is what you're doing. You're putting the synovium back rather than closing the arthrotomy. And that is where I've done this lateral approach couple of times. And the problem is that when you corrected such a big deformity, it's struggle. And I think Peter Kiblish discussed cutting the fat pad in and flapping it back.
Yeah, same thing. Everything has been replaced. The fat pad, the meniscus, what are the tissues that all the tissues are replaced to close the lateral side. If you want, I can show that again. And regarding the first thing,
the panel's opinion whether quadriceps snip is too much to do for a primary total.
So I think other cost is tibia tubercle osteotomy. I mean, if you don't do a snip for giving an exposure and for going onto the posterior medial side.
But if you don't do the lateral approach, you don't need to do that.
Yeah.
However, with the deformity, you do the medial approach, you can get exactly the same exposure and you don't have to do any of this.
Yeah, in a
Rajesh,
situation,
I agree with you. The Kiblish approach.
Snip. Yeah.
But
unless it is a very stiff knee.
Hello. See, the Kiblish approach, whilst it is just, it is one of the things that surgeons have evolved as part of their repertoire. But I agree with Rajesh that whilst it is necessary to know that such an option exists, the vast majority of arthroplasty surgeons would be well counseled to understand that it is quite a disorienting experience to do this entire procedure with the patella and the quadriceps mechanism on the opposite side than what you are used to, number one. Number two, you also saw in Satish's demonstration that you need to take the skin flap right down to get all this. And I would be sometimes, especially in a thin rheumatoid knee, I would be worried about the skin vascularity, where there is hardly any subcutaneous fat available in some of these skinny knees, So whilst it is a very lovely demonstration of the Kiblish approach that Satish has shown, but I think Rajesh's thrust of his question is that it is probably not an approach which one should take on all that easily, because the medial parapatellar is sufficient in delivering almost always the ability to do
Bharat, well taken up. Can we have Dr. Barad's opinion, because you have worked with Dr. Kiblish? So any input from your side, Dr. Barad?
Well, I think lateral approach is interesting when you have a subluxated fixed patella before surgery. So then I would go laterally. And when I have a fixed deformity, I think I use all the tricks to lengthen with the synovium, as Rajesh would say. And I keep my flap. I don't have this complication, but at the beginning, you have to learn. You have to become very familiar with this approach, and you can see so well. But I agree that it's a more difficult surgery at the beginning. I never need any snip on the quadriceps. So, well, I'm used to it. We have no patella complication. We look in the French Orthopaedic Society, when you use a lateral approach, you have no patella complication.
So, Dr. Krishna, your last question, and then we move on to the next speaker.
The question for Dr. Brad, another question from Dr. Harpreet Singhil, that Dr. Brad has one of the largest series in rotating platform. Is he still using RPF knees for valgus knees or doing fixed bearings? Dr. Barad, you were using LCS rather, if I remember right. So are you using mobile platforms or you move on to fixed bearing?
No. Well, so it's a big question, mobile bearing, why to use it. And to see a difference, I think we know now that you have to look at more 15 years survivorship. So I still think it's quite interesting, and I think it's adjust the rotation on the tibia. But that's another discussion. We have to be careful with mobile bearing. if the hip, you have to look at the hip and the foot. And if each time this patient is walking, it's in an external rotation. I have one patient, I have only one. My pathology was well centered at the beginning, and after years, I can see some subluxation happening. So maybe when you have a bad hip and a bad hind foot, flat, you may prefer to use a fixed bearing hinge.
Yeah, Dr. Krishna, the last question, and then we move on to the next talk. So, Krishna, do you have a last question to put on?
Yeah, so my own personal experience has been the wound healing is an issue with the lateral parapatellar approach. So, and second is you could have catastrophic instability suddenly because you've done so much of lateral release of the soft tissues. And I saw that Satish had used a sort of a lateral pivot type of an implant or something. So definitely, my question to Satish is, would you use a PS or a higher constraint if you do a lateral approach? And what is his experience with the wound healing? So one, Dr. Rajesh rightly raised lateral. You need a rectus snip definitely for good exposure, unfamiliar approach, too much of release, and maybe incidence of instability later on. What sort of constraint you must use, and what is a wound healing complication? So
wound healing complication, yes, if you take the skin incision in the midline, that's what we have been taught. But here the incision should be on the slightly lateral side. As I said, the skin incision will be on the lateral one-third of the patella or on the lateral edge of the patella itself. That way, that has avoided almost all the skin complications. And regarding this extensive dissection, I can't understand. You yourself told that you have released IT band, you have released postoperative from medial side. I'm doing from the lateral side. What else I have done?
no, but there is a difference. You will not release the IT band in total. You will release it from its insertion, Guddy's tubercle. So the itself is intact.
From where you are releasing from on the medial side, where you do surgery on the medial side, from where you are releasing the IT band?
Will release from the Guddy's tubercle, but it's not to that extent. Posterolateral corner.
No, it is. That is not. No, that is decided by the deformity. That is decided by the deformity. The extent of release of IT band is decided not by the approach.
So Krishna, that's one way to look at it. And guys, we are passing with time. So can I request Dr. Rajiv to start his presentation now? Thank you, Dr. Satish.
Thanks.
Thank you, Manoj. Thank you. Can you see my screen?
Yeah, we can see your screen. Yeah, we can.
Okay. Friends, good evening. It's a wonderful time that we are discussing on the online because of the obvious situation of COVID-19. It's a good approach of Indian Arthroplasty session to start a new web series, and hopefully we'll be carrying it on in time to come as well. I'll be speaking on significant tibial extraarticular deformity, which is post high tibial osteotomy. Now, this is the patient who is 51 years, operated in 2006 by me. She had the high tibial osteotomy 10 years back. And the incision, which we'll see in the next few slides, is very much lateral incision for the high tibial osteotomy. So that was the pre-existing incision. This was the X-ray of the patient, which was the overcorrected high tibial osteotomy. It was the anterior translation of the distal fragment as well. Significant patellofemoral osteoarthritis and very significant amount of valgus. Also, some amount of laxity on the medial side. We'll see on the when the patient is walking, we can see that there is it's not just the valgus knee, it's also a stretched medial collateral ligament in this patient. Opposite side is non-operated, slight varus, and some amount of medial laxity. The plan for this patient was total knee arthroplasty and correction of the high tibial osteotomy. Our goal was the aligned limb, mobile knee, stability and durability. Bone cuts were the issue, the soft tissue balancing was the issue, and the reliable fixation. What we aspired was a neutral alignment of the limb, rectangular collateral frame inflection and extension, and a good patellofemoral alignment. And redo high tibial osteotomy was found to be a very good method in this difficult case. We followed the knee kinematic theory, the soft tissue balancing to allow the knee in inflection and extension. First, the balancing was done in extension and then inflection. Distal femoral cut first. We used the help of the computer-assisted surgery in 2006. Tibial cut was in line with the posterofemoral cut because that was the most difficult aspect, how to make a tibial cut in this situation where you have a high tibial osteotomy with so much of significant deformity. We created the gap in the femur, between the femur and tibia. We rightly rotated the femur, the right amount of external rotation and proper tension on both collateral ligaments. I used the middle parapatellar approach. Why? Because one, that this patient had a pre-existing lateral, very much post-lateral, almost the mid-lateral incision for the high tibial osteotomy. So wanted to keep the now present incision much away from this incision for healing purposes. And we plan to do a redo osteotomy. Steps was computer-assisted surgery for femoral cuts. Tibial cut has to be perpendicular to the tibial mechanical axis. Ligament balance, because that was the issue, because we had the medial laxity as well. Which procedure was to be used and what kind of a postoperative special care, if at all, to be done. The femoral, once we did the right kind of femoral cuts and we did the knee cuts, the bone cuts were almost as good as for the normal knee replacement that we do. And then at the center of the axis of deformity, we did the high tibial osteotomy. And that was the situation. The osteotomy cora was almost here. We did the osteotomy. Initially fixed it up with a staple. Used the normal PFC sigma implant. Extension stem in the tibia, tightening of the middle collateral ligament, and of course, this patient was given some amount of postoperative support as well. You can see that this kind of a hinge brace was given. With this, the patient was able to do a good amount of flexion extension. We can see that the patient is able to have a good amount of flexion and good alignment and extension. That's the patient's x-rays. This patient around 7 or 8 years post-surgery. We can see that walking balancing is good. The function in flexion extension is very good. This patient was able to follow almost very easily. The gait was excellent. Thank you so much.
So any questions from the panelists? Yeah, Rajesh.
Rajiv, great work. I want to ask you that this particular case probably had a little extra valgus on the osteotomy side, and therefore you needed to do the osteotomy on the tibia. But otherwise, normal high tibial osteotomies, would you need to do a osteotomy like that, or you can just correct it?
With this much of deformity, if we see the preoperative X-ray.
Yeah, so in this patient, I think the original high tibial osteotomy has brought quite a significant of correction.
If we wanted
but,
to...
Yeah. No, Rajesh, the articulated question is, in how many % of cases post-STO do you require a re-osteotomy? Is that right, Rajesh?
Yes.
Rajesh, in most cases where you have a not so significant a deformity, probably you can do the intraarticular correction for these deformities. But where you have a extensive, the huge deformity like this, then probably intraarticularly, if you are correcting, then we'll be having a lot of problem in the soft tissue balancing. And the only way will be to use a more constrained implant.
Yeah, I agree, absolutely. Did you put a bone graft in that osteotomy site?
Yes, the best advantage of an osteotomy in these cases where you have to do the osteotomy, you take out a lot of graft at the time of bone cuts, and that graft is a very good material for bone stimulation at the osteotomy side. Now we have a large number of these cases where we did the high tibial osteotomy or the osteotomy at a distal level in tibia or femur, and this bone graft does come as a good help.
So one last question, that stem that you put, if you can go back to that X-ray, you know, because you're almost always worried about the stability of the distal fragment just with the stem.
Yes.
Go to the post-op X-ray, sorry.
But you see, Rajesh, if you are able to fix have a good, good purchase in the tibial cortices, then it is not major issue.
So Rajiv,
Right.
here your choice is a cemented stem or a press fit stem. What would you choose today?
No, a press fit stem, for sure. And I'll cement only the proximal part of the stem.
The hybrid fixation that you're recommending. And Rajiv, can we request you to stop sharing so that Dr. Anand can put up his slides, and the meanwhile we can take more questions from the audience?
From YouTube, there is a question that what level did you do your osteotomy, Rajiv?
In this particular patient,
By Dr. Singh, Dr. Harminder Singh.
Yeah. Subhashu, in this particular patient, I did it quite proximal because the deformity was at that level. But in cases where it is the deformity is not the axis is not so proximal, probably a little more distal osteotomy will be easier. But in this patient, because the earlier high tibial osteotomy was not just at this level, but it was also it was shifted anteriorly. The distal fragment was shifted anteriorly. That's why it was very important here.
One more YouTube question.
Dr. Anupam Srivastav, why not plate fixed after the osteotomy?
It is not required. If you feel that your stem is not fixing very well in the distal tibia, then yes, the plate fixation is must. But if you feel that you are having you should use the sufficiently long stem, which is purchasing in the distal tibial cortices very strongly, and then you don't need. The maximum that you can need is that you can give some kind of a post-operative support, like you saw in this patient, the hinge brace. That too for a period of a month only.
Dr. Deepak Dave, that you did the tightening or medial collateral ligament, the plication.
Yes.
How was the tightening was done? That means how did you decide at how much plication is to be done?
Because the pre-operative, we also knew that this patient is having some amount of medial collateral ligament stretching. So I was prepared to do it. That's how all the preparations were there in the OT. And it works very well. We have done many cases where we have done the ligament augmentation. In fact, with Dr. Briard also, we've operated quite a few patients of MCL laxity in difficult situations. And this ligament augmentation does work very well.
Dr. Meenal Sharma did tibial osteotomy.
So,
Yeah, Dr. Briard, do you want to comment something? Yeah.
Yeah, when you do your planning, you draw your tibial mechanical axis and you draw the tibial cut. So you see how much medial condyle you will have to excise. So if it's a big overcorrection, I think release will never work.
Yeah.
So then you have to you can decide to use a very constrained knee. But if you plan to excise too much of the medial condyle, I think it's not an indication for release. Then you should do an osteotomy. If you remove little from the medial plateau, I agree with Rajesh. I think you do pie crusting and it's okay.
Yes.
So you're planning an X-ray. When you draw the line, it tells you what you will do.
And wherever, Subhranshu, we feel that there is a problem of the ligament augmentation is not enough, collateral ligament augmentation is not enough, I think it's okay to use the more constrained implant, and that is preferable. I agree with that.
Okay. Dr. Indrajit Sardar is asking, was there a shortening in that case?
No. As you could see when she was walking, there were no shortening in this case. Because you see that when you correct the deformity from the valgus to neutral, you do gain some amount of length. In fact, the problem in these cases is that you may gain more length, and that is what you have to be careful about.
So Rajiv, I'm going to shoot you the last question before we move to the next talk. And that is a pretty simple basic question. In all these valgus deformities, what is the femur valgus correction angle you take and why?
In this patient, because we did it with the computer navigation, so the valgus angle was decided as per the what the computer decided. But in otherwise, I will, because in this particular case we were doing the in the joint, the bone cuts were as if for a normal knee, and just the tibial osteotomy to correct the deformity. But otherwise, in all valgus knees, I take the 3-degree valgus.
Reasons?
Because the alignment is better. The 5-degree will keep the patient in some amount of valgus. So I think that is the basic.
So just a moment, Manoj. I would like to question Raju on this. So if 3 degrees is better than 5, why do you normally take 5 in your varus knees?
All the varus knees we take 5 degrees.
So why? Why the difference? If it is about 3-degree being a better alignment than 5 in a knee, why have that change in a valgus as compared to a varus?
Because we do not want to leave our knees in under correction.
No, so let him answer, man. I know I didn't.
You don't need another webinar. It's another subject, very interesting.
But the valgus knee is not like a varus knee. Varus knee, we decided that 5-degree valgus is right for on an average for our patients. But in valgus knees, if you cut it 5 degrees, then you might leave the patient in some amount of valgus.
No, if you are cutting it at 5 degree, you leave the patient in 5-degree valgus. But there is a reason why we try to minimize the valgus knee, valgus angulation on the distal femur in a valgus knee as compared to a varus knee. Yes. And correct me if I am wrong, my friends here. But the reason is we do not want the weight transmission and the stress on the medial side the same as you would have in a varus knee, because those medial tissues are already have been under threat of some amount of compromise. And if you leave the knee, if you leave the residual alignment of your knee a little bit in favor of those medial tissues, it's a long-term construct which will be helpful in not having unintentional stretching of those tissues. Right. And that is personally the reason why I normally in a valgus knee would go for a lower valgus angle as compared to what I would do in a routine varus knee. But
also it makes.
Bharat, I have one say here that there's hardly any difference between the 3 and 5 degree. The 2 degree is very difficult to measure. If this is a 3 degree and a 7 degree, then I can understand.
The CAS guys will tell you a lot of difference, Sanjeev.
Yeah. So just talking about 3 and 5 degree for 1 degree, I think is just not justifying.
No.
I think in my understanding, the angle when you are using mechanical axis, instead of cutting 5 degree, you cut at 3 degree, because in a valgus knee, there is a realignment of the mechanical axis of the femur vis-a-vis the anatomical axis. The normal angle is lesser on a valgus knee, and that is why if you're using a mechanical jig, you should cut less amount of valgus on the femur, because it is already in valgus. And I think for a CAS user, this is great. You don't have to think about it. You just cut 0 degrees to the mechanical axis.
Yes.
So Ronan, can we start with the next talk?
Yeah. I'm ready. If you can stop sharing. I can't share mine.
Rajiv, you have to stop sharing yours.
Rajiv, you have to stop sharing your screen. Stop share. It is on the top.
Stop at the top. Stop share. It'll be at the right at the top.
Yeah.
Right.
So in the meantime, there is a question from the YouTube. Does 3 or 5 degree increase chances of common peroneal stretch? I don't think so. I think all the panel agree.
Hello. Let that question remain for my case. That is exactly what I am going to present.
Okay.
Bharat Bhai will answer that question later on.
Whenever we reach, even in at midnight, but I mean, that is when I will answer.
Common peroneal palsy, what my experience, if your handling is good and you are in a valgus knee, you are not trying to overstretch it, then probably the common peroneal palsy is not a major issue. I think the soft tissue handling is the most important.
Okay, we go ahead with the next presentation. In the meantime, I request Dr. Rajiv to answer the questions in the YouTube, and I'll mute all of you.
Any questions, Shubhranshu? Not able to hear.
You answer in the YouTube. You type it out. You open the YouTube in your mobile phone and answer your questions. In the meantime, Dr. Ronan will go ahead with the presentation. Dr. Ronan, will you unmute yourself?
Right. I'll be talking about 48.
You have not shared your screen.
I think he's in a weak signal.
Yeah.
He can stop his video and then only do the presentation with audio and then come back live.
Now he has left the meeting.
So,
there is no problem.
Rajkumar, can you start your talk in the meanwhile?
Yeah.
Your case in the meanwhile. Yeah.
I think I have the next presentation, Manoj. I am next on the list according to what you sent.
Okay. Anup, you can start.
Yeah.
Who has to start? I have to
start? Anup, you start up.
Yep.
Yeah, when he is sharing his screen, there's a question from the YouTube that how much valgus can be corrected in the tibial side intra-articularly in a case with STO? Rajiv, would you answer that question? That is a question from Dr. Satish Nesari. You have to unmute yourself.
If it's extra-articular deformity and far away from the joint, then it's not major issue. If it is a closer to the joint, then probably you can correct up to about 12 to 15 degrees. You can correct very easily within the joint. But as much the deformity is moving away from the knee joint, that much it becomes difficult to correct.
Okay, thank you. Now,
okay, can I share my screen now?
Yeah.
You can see that.
This is my screen. So, what do you want me? You want me to continue?
Yes. You start from the first one.
Yeah. All right. So this is a 50-year-old rheumatoid lady with bilateral valgus knees, as you can see. And though both the knees look similar, this is the importance of taking long X-rays, and you can see something there. Though we take full-length X-rays in every case, but I think valgus knees and knees with extra-articular deformity, it's more pertinent. But I think it should be done in every case. Now, this lady is a rheumatoid lady, and we should see the hips and the ankle feet. Sorry for that. We should see hips and ankle and feet in these patients. And this patient had a primary THR 20 years back and a revision THR 5 years back. So you can see that though the valgus and short X-rays look similar, it's much more severe on the left side, and both have got long stems. So this is an absolute indication for CAS. So we should do it in every case as per what we do. Now, what CAS does is that it gives us an objective assessment of the deformity. And it also takes out guesswork into the flexion planning of the knee that we have been talking about for the last 1.5 hours. So valgus is 27 degrees and flexion is 26 degrees. So this is a valgus flexion deformity. That's one thing that we know. We can draw our lines on the X-ray and find out, but we don't know exactly how much the flexion deformity is. And even the valgus deformity, we tend to underestimate. That's one important point. Second point is that we plot a graph whenever we take the kinematic moment in CAS, And if the graph comes here, that means the knee is remaining in valgus. That means it is tight on the lateral side, even in flexion. So the main advantage of CAS is not only the coronal plane assessment, the sagittal plane assessment, but the flexion behavior of the knee. That's the most important part of CAS. And if the graph is going like this, that means it is tight in flexion. We may need popliteus release. That's one thing. Now, this is a flexion deformity of 27 degrees. You can see distal femur cut. We just taken a +2, not more, and we'll come to that. Tibia cut, we have taken a 7 or 8, not much, because these knees tend to open into flexion, the valgus cases. And this is FFD, so we have taken a +2 on the femur. Now, this is the graph on the right bottom is before any soft tissue release. Now, here you can see 5-degree valgus still and a 14-degree flexion still. So we still need correction, but we don't need more bony cut. The reason is, when we correct the coronal plane deformity, that is the valgus, the FFD also corrects. So correction of the coronal plane deformity corrects the sagittal plane deformity also. That's an important message. Now let's look at the soft tissue balancing of this particular knee through this video. So this is the knee in extension. You can see the CAS pins. The laminar spreader is on the medial side. You take a long cautery tip, not the routine one, and keep the cautery on 30 or 40 and feel and cut the curtain-like capsule in extension. Then to correct further under navigation control with 11 number blade, the IT band, which is just below the quadriceps tendon, and check again periodically. It doesn't have to be sudden release. It has to be a graded, guarded release under control. And because we have navigation, we have data in front of us as to where we want to leave our knee. And you can see here, we have 2-degree valgus and 5 degrees of flexion. What is more important is that the yellow graph that we see now is just above the midline, and that's where we need it to be. It's still tight in flexion, and you can see that the knee is tight in flexion. And this is when we can release the popliteus. We can do pie crusting, and we can do a partial release just to open enough for our poly to walk in easily. And this is an indication if your knee is in valgus in flexion, then you need a popliteus release to balance the knee. One of the reasons of big more medial opening is poor balancing of lateral compartment in flexion. When you balance that, when you release the popliteus under control, your knee falls very nicely into a rectangular gap. So you can see that this knee is nicely balanced now. This is what our final aim is, to leave it in 1 or 2 degree valgus and correct little more flexion up to 7-8 degrees, because this is a rheumatoid lady. You can see the final post-op X-ray. The tibia cut may look in varus, but it's not so. It looks like, because the tibia is in valgus, and you can see here that the tibia has a valgoid bowing. This is the immediate post-op X-ray, and it's interesting to observe that after 3 years, this extra valgoid bowing, which was due to lateral compartment loading, corrects itself when we remove the degenerative process. And you can see we are following these patients for a long time and observing what happens to the valgoid bowing of the tibia, and that tends to decrease once the load-bearing axis comes to near neutral. 1 or 2 degree valgus is also an advantage to the hindfoot valgus that the patient has. And once the valgoid bowing corrects over years, the knee becomes nice and neutral. So the message from this case is to use CAS in these cases to see the kinematic behavior of the knee in flexion, and that will tell us whether we need popliteus release or not. Thank you very much.
Wonderful, Anoop. I think the talk is open for our panelists for discussion. And by the time I have one question, Anoop, normally in all severe cases of valgus, you have external rotation of the tibia. The tibia goes to it. How do you manage that?
Well, that corrects pretty much when you do the IT band release, because the external, even Bharat was talking about recurvatum. So recurvatum and external rotation is because IT band contracture. Once you release that, tibia falls very well in place.
Manoj,
yeah.
Manoj, see the incredibly important difference between varus deformities and valgus is that you have one of the most powerful muscular dynamic type of a deforming force in the form of IT band and tensor fascia latae upstairs, which is an incredibly powerful and dynamic deforming force on the lateral curvature, problems like valgus as compared to varus. And that is why even during Krishna Kiran's case, I was just mentioning that to do anything more than what is required before you adequately titrate and release that dynamic force, from its deforming ability, it would be a mistake. But one thing, Anup, that's a beautifully demonstrated event that you are showing here about even in adults, how gradual remodeling might be a process that happens, over a period of time once you have done and that also brings Rajesh's point earlier, which he said, that there are adaptive changes probably in valgoid knees, even in the terms of the anatomical axis being a bit different as compared to the mechanical from the routine varus type of thing. So that's a very important takeaway, I think, for all the audience as well as for people like us. Very nice session.
Well, one thing, Manoj, that in these cases with the valgus knees, the rotation, external rotation of the femur, I always tend to increase a little bit as per the requirement. Because all these valgus knees, they have the more condylar twist angle. It is a better way. Otherwise, you will be keeping some amount of internal rotation and the flexion is limited.
So I have a question for the panelists and especially Anup and you and Dr. Baryard also. Now, as a message for all the attendees listening out here, we all know that the culprit is an iliotibial band. So what do you advocate as a message? Pie crusting, releasing from the Gertie's tubercle, or going from outside and releasing it and transecting the IT band? So what is the best way, Dr. Baryard and Dr. Anup, that you would like to convey across to the listeners?
See, it will
Dr.
depend
Anup,
on
just 1 second. You have to stop sharing your screen so that Ronan will load in the meantime.
Yeah. So it depends on the deformity, and we have to do under navigation preferably because we have a visual assessment. So our objective is to leave it in 1 or 2 degree valgus and flexion of 5 or 6 degrees, and we'll keep doing pie crusting or posterior lateral capsule till we achieve that after removal of all osteophytes. And osteophytes in a valgus knee are often underestimated. They are pretty much on the tibial side, which you don't see. So we have to remove all the tibial osteophytes.
So how do you do pie crusting of tendon of Popliteus?
With an 18 gauge needle. With an 18 gauge needle. And we do it under navigation, and we know that we suppose the gap is 18 and we wanted 20. So we'll keep needling it till we achieve 20. And if we can't,
full
then
thickness,
we do
full thickness puncturing. You mean full thickness puncturing of the tendon?
That's right. It's described in literature also.
Yeah. So Ronan, can we start with your talk? We have a couple of talks after this also.
Sure. Well, at the beginning, outside, I'd just like to apologize because I'm having problems with my bandwidth. There's a heavy storm on, and I hope that you guys will be able to see most of my talk. I'll skip the videos as far as I can. That'll hopefully make it easier. Well, the patient that I'm going to present is a 48-year-old female. She's had a long-standing history, controlled now with DMARDs, and has no medical problems. And this is basically her knee as it is at the moment. And you can see that she has a valgus deformity of almost 30 degrees on the right side, which is more affected
Ronan,
than the left.
Ronan, can you just stop?
Standard valgus deformities in most cases. Hello?
Ronan, your
Hello?
voice is cracking. I think you're in a weak signal zone.
Okay. Can you hear now?
Yeah, we can hear you better.
Okay.
Just keep the audio on, then the bandwidth.
Yeah. Okay. The three main techniques that we have is, one is the periosteal technique that we've already seen, and release of the IT band from Gertie's tubercle, as Krishna showed. And unfortunately, it's long-term studies of these have shown that there's almost a 24% instability in these patients in long-term follow-up. And as a result of this, the run-out technique was introduced, which is an inside-out technique. And this is actually what I will be discussing with you today. The run-out technique basically starts with the PCL is cut right at the beginning. The tibia is cut along with the distal femur, and you balance the extension gap first, do your soft tissue releases, and then finally turn your attention to the flexion gap, adjusting the femoral rotation. So let's look at this in slightly greater detail. Basically, after the distal femoral resection and proximal tibial resection, in a valgus knee, you'll have the tight structures medially, and obviously you'll have a trapezoidal or unbalanced knee. And the way that this is done is by doing an inside-out release of the posterolateral capsule. And this is the video that was very aptly demonstrated by Anup in his talk, which was supposed to follow mine, but unfortunately, as I said, he had to come before me. And during this time, it's important to remember that where we're doing this release, you've actually got the posterior, the common peroneal nerve. And this lies in the triangle that is below bounded by the gut surface of the tibia, the popliteal border. And following this, you do a pie crusting of the iliotibial band either with a 15 blade, as Dr. Ranawat has promulgated, or with an 18 gauge needle, as Shubhranshu Mohanty just told you right at the very beginning. Now, this is the way that this is actually done. So right at the bottom, you go parallel to the tibia, just above the tibia. Make sure you don't pierce too far, because you've got your common peroneal nerve right behind you. And with your diathermy, you do a posterolateral corner release. Followed by this, you do multiple stabs with a 15 blade. And this have to be in a graded fashion as Anup just showed. You don't do 4, 5, 6 stabs at one go. You do 1 or 2, and then you check. If it's not opened up, you do again 1 or 2 and check. And it's, if you've given too much, then you would end up with laxity. And this is what it looks like during the surgery. I mean, you've got the popliteus tendon lying over there. This is your posterolateral corner. This is where you do your release just below or parallel to the tibia. And this is your iliotibial band where you do your pie crusting with your number 15 blade. And after this, you check your alignment and balancing in extension. So basically, you've got your extension balance sorted out. Once the extension balance is sorted out, you then turn your attention to balancing inflection. And the way that this is done is by determining the femoral rotation. Usually the landmarks that we use for femoral rotation are the epicondylar axis, your condyles, the white sides line, and the cut surface of the tibia. And the effect of this rotation is actually on the flexion gap symmetry and patellofemoral tracking. But unfortunately, there is hypoplastic lateral condyle, and this causes problems with normal referencing, as a result of which you want a rectangle, and the way to achieve this is by making sure that you balance your flexion gap by adjusting the cutting block so as to do the cut surface of the tibia, so that you end up with a rectangular gap. And after you've made your cuts, you should be able to put in your spacer, and it should be parallel and well balanced. So once the block is out, you should actually have a space that's looking like this. So, and at the end of your chamfer cuts, this is the way that the patient's knee looked. Again, a rectangular gap, which is well balanced. And in fact, a medium to long-term ability by using this procedure. In fact, this has actually helped in surgeons and has become probably the most utilized procedure for medium to moderate and even to some severe cases of valgus deformity. However, there are some points that you need to remember when you're doing the run-out.
So Ron, can we take your slide on for questions? Yeah.
Sure. There's a possibility of peroneal nerve injury. You need to check the patellar tracking, and this is the patient's results. Thank you.
So, Raj, you can put up your screen. I have a question for you. Dr. Manti, in the meanwhile, you can start plotting the questions that are there on the YouTube. So, Ronan, whenever you use a Ranawat block, and in order to balance your valgus knee, you have to put your block in external rotation. What has been your experience and your message to the audience? Because there are issues where you get anterior femoral notching by doing that external rotation. And also there is a maltracking of the patellofemoral axis. What is the way you get across these problems?
Well, there are three problems actually. One is you've got to be very careful regarding your common peroneal nerve. That's the most important thing. Secondly, as you rightly say, there is a problem with patellar maltracking, and the incidence of patellar lateral retinacular release is quite high. And you've just got to, if necessary, upsize your femur so that you actually try and avoid notching. So these are the three things that you need to be careful of when you're doing the Ranawat technique.
Yeah, most important thing what he showed is the danger zone, the triangle formed by the tibial cut surface, the popliteus tendon and posterior margin of the IT band. In this triangle, you have to be very careful to do the pie crusting, because there, if you go deeper, there are chances of injury to the peroneal nerve. The safe zone is to the IT band. Now, the question is from Dr. Devashish Mishra for Dr. Anup. Do you ever do pre-operative CT scan rotational sequences? Question to all panelists to summarize the sequence of release for valgus knee in both flexion and extension. Yeah, Anup, can you do you do CT scan for rotational?
CT scan, yeah, we will do in cases in which there is we expect a rotational deformity. So there are cases of distal femur fracture malunited and external rotation. There it is wise to do a CT scan to see where the actual epicondylar axis is in, and with cast to adjust to it. So it is indicated post-traumatic cases, number one. Number two, sequence of release, I think we have discussed.
Yes, Dr. Indrajit Sardar, question to Dr. Anup. Did you consider a lateral epicondylar osteotomy at any time instead of a popliteus release?
No, because once you do your osteophyte removal and everything, I was at about 7-8 degrees, and I showed that 7-8 degrees, if you are there, then you know that you can correct that deformity by soft tissue release. If after osteophyte removal you are at 15-degree uncorrectable varus, or 12 to 15 degree, then I would do osteotomy straight away without doing the releases. So you can't do both of the things. You have to decide about osteotomy early on.
Okay. Dr. Anupam Srivastav, can we decide pre-op tibial slope?
Is that to me?
Yeah, anybody can answer.
Yeah, so we have to see the X-ray. If it is a recurvatum case with valgus, it will have a neutral slope. We can determine that with CAS, but routine case like the one I showed will be 3 to 5 degree for a PS knee.
Okay. The sequence of release, Dr. Devashish Mishra has asked, there are different authors have given different sequence of release. Krakow, starts with the IT band and then does a posterolateral corner. And Ranawat goes with a posterolateral capsule followed by IT band, in this way, but nobody recommends a popliteus release. It should be the last option because popliteus usually released in a tight varus knee. That is the most important lateral stabilizer. So everybody avoids to release the popliteus.
No.
In fact, release of popliteus has been shown to have long-term instability. If you have to release the popliteus, long-term instability is much higher.
Gentlemen, I just want to bring this, I think we are probably blowing out of proportion the importance of popliteus as a stabilizer to the effect that it will cause instability. Popliteal release might cause instability when you have already done some other releases. In so many times, I think each one of us would have seen that in a tight knee, in a very standard knee, I'm not talking about valgus knee, when you do your posterior condylar cut, your saw blade.
That's just the point, Bharat. That's just the point.
Exactly. So the popliteus as a tendon has to be carefully preserved in a valgus knee because you have already released so many of the other lateral popliteal structures, I mean lateral tight structures. But otherwise, we can't give the importance to that tiny little muscle of being the main stabilizer of the knee joint on the lateral side. You know?
Especially Bharat, in a stabilized knee, you're right that it doesn't matter much. Many a times by mistake also you can make a partial cut in the popliteus. It doesn't matter.
In my presentation, I'm going to show what Subhranshu was just trying to summarize. In fact, I haven't touched on any of these other aspects that you gentlemen have so comprehensively covered. In my presentation, it's all about the different sequence of releases that different authorities have propounded over the years. It's just a comprehensive sort of a cataloging of that.
I think Bharat Bhai will answer there all that.
Yeah. So Subhranshu, if you permit, can we start with the next talk?
Yes, please.
Dr. Rajkumar to continue with this.
Yeah. Okay. Good evening, everyone. And so till now we had excellent talk and discussions on approaches and release. And in fact, Dr. Bharat towards an implant related. Okay, 1 second. Okay, so this is a 60-year-old male. He's a known rheumatoid arthritis on DMRDs and steroids. He came to me 1 year back, even before this X-ray. 1 year back, he came to me. That time itself, I advised him a total knee replacement, but he refused and he went back. He was from Maldives and he went back. And again, 1 year later, he came to me in this situation. Like he had a supracondylar femur fracture, but surprisingly, it was not a very big fall. It's a trivial fall, and he had a fracture. And then he had a difficulty in walking, and the deformity was progressive. And he was a known diabetic and also a chronic urinary tract infection patient getting treatment with the urologist. If you look at the clinical examination, the range of motion was like both passive and active was having hyperextension. It was going into recurvatum, and the instability was grade 3 mediolaterally, and also, but the neurovascular, clinically, the neurological status was reasonably normal. Almost the power was all normal, and his spine was also normal. Initially, I thought of even it can be a neuropathic joint sort of thing, but because of his trivial fall, and he didn't have much difficulty in walking, only later on. So this is a windswept deformity like of right side varus and left side gross valgus deformity with severe bone loss. And if you look at his left knee angle, it's so much of valgus is there, and because of not only because of the tight structure, because of the malunited femur, and also because of the bone loss on the tibial side. So if you look at that walking video of this patient, he was able to walk with the crutches and even without the crutches also. And you can appreciate here how much of hyperextension the knee goes into. So much of hyperextension, but in spite of all these things, he was able to walk even without support. But he was using the crutches for regular commuting, but I asked him to do, then he was able to. So coming to the management plan here, in this case, definitely needs a total knee replacement. But the approaches, there were two schools of thought, whether to do a lateral approach or a medial parapatellar approach, like as we discussed earlier. In this case, I did a medial parapatellar approach. The question is the implant choice and the level of constraint. The difficulties, if you see here, is the severe valgus deformity, the gross hyperextension, and the bone loss, both on the tibial side and the femoral side, particularly on the tibial side, both medial and lateral. That also will be giving a lot of mediolateral instability apart from the tightness and the malunited supracondylar femur fracture. In this case, a CT scan was done, but I don't have the pictures here, but the CT scan was done. The lateral, some amount of union was there on the lateral side. Even though the medial side, not much of union, but the lateral side, that some amount of union was there. So my plan was to do a medial parapatellar approach. I had both the systems, the TC3 constraint system with the metaphyseal sleeves, the constraint system for the severe valgus and the metaphyseal sleeve to address the bone loss. And I also had the rotating hinge knee system as a backup. My predominantly the hyperextension was the one which made me to go for this hinge knee system as a backup. So if you look at this clinical picture, as soon as I opened, this was the bone loss I had on the tibial side, both on the medial side and on the lateral side, such a massive bone loss, and also the totally deformed tibia. So after the cuts, if you see here, after the cuts, the lateral side also there is some amount of deformity here with deformed bone and so much of bone loss from anterior to posterior side. And straight away, then I decided, because of the deformity defect was so much down, then I decided that this has to be managed with a hinged knee processes. So I prepared both the femur and the tibia for a hinged knee. I used a metaphyseal sleeve. This is the Depew SROM Noyles rotating hinge system which I used. So I went ahead, and the tibia supracondylar fracture lateral side was well united, but only the medial side there was a gap which I curated and packed with the bone graft. And this is the after the implantation, you can see the amount of the depth of the defect which is going posteromedially down. So this is where almost it has crossed the level of your medial collateral attachment as well. So I didn't want to take a chance. Straight away I used a hinge process. This is the postoperative X-ray, and the patient after 2 weeks was able to walk. I used a hinge knee brace just for a added support for 4 weeks. So this is the postoperative X-ray. So coming to the quick literature 3 slides I have. This is about the primary rotating hinge total knee replacement in a primary situation, midterm follow-up, 43 to 72 years in 2014. The series was limited to complex primary, minimum follow-up of 10 years, and they have concluded that none of the modular rotating hinge components were revised. And the hinge process are viable option for a primary TKA in a MCL deficiency and severe bone loss with advanced joint destruction. One more paper in 2017, yes, the rotating hinge construct has a low rate of aseptic loosening even at 10 years. Why? Because of the advanced hinge process. These failures were very high in the old systems, but in the recent ones, with the advantage of metaphyseal cones or sleeves, seems to have a protective effect on the rate of aseptic loosening. From the endoclinic, they have very clearly mentioned about the indications: collateral ligament insufficiency and bony destruction of the tibial plateau, hyperlaxity, fixed valgus, and severe rheumatoid. All these things, but in this paper they have quoted about in old age patients, but there are reports in younger age also which the hinge processes, rotating hinge, doing good. Mainly the surgical tip is the maximum rotational stability of the femoral implant has to be addressed. The rotational stability of the femoral implant is the most important thing. That gives weightage for the longevity of the implant. And the rotational orientation of both femoral and tibial component has to be very, very correct, because especially in rotating hinged implants, as the increased internal rotation may lead to lateralization of the patellar tracking. So a take-home message: in a severe valgus, a constraint process like a PFC, TC3 or a CCK should be the first choice, definitely. But in some instances, however, in a severe valgus with a bone loss and hyperextension deformity, rotating hinge process should be considered. If rotating hinge processes, then metaphyseal sleeves or cones are a good option for longevity. Thank you.
Thank you, Raj. Now, any questions? Any questions from the panel?
Questions from YouTube by Dr. Rajiv Kulkarni. In case you showed patellar resurfacing was not done, any thoughts on that? Rajkumar? Rajkumar, question for you. Hello. Dr. Rajkumar, you are able to hear me? Dr. Rajkumar. Hello.
Hello. Yes.
Yeah, the question for you: why you didn't resurface the patella?
Yeah. No, here I had a very good tracking, and normally I don't resurface the patella at all, unless otherwise there is any issue. Otherwise, I don't resurface my patella at all. The tracking was excellent. I didn't do any lateral retinocular release in this case, and I had an excellent tracking. So I don't need to. I didn't do a resurface.
There is a question for Anup that do do you ever do preoperative scan for rotational sequence? That you have answered already, I think.
So Rajkumar.
Yes.
Yeah. So basically, when you are using these sleeves, especially in an Indian patient and a porotic bone, very small bone, what tips you would like to give? Because sometimes these sleeves, even the smallest one, is quite big for an Indian bone and porotic. So I'm sure that some thoughts to be given to the younger colleagues.
There is one good question is point is, most of the time in revision scenario, old ladies osteoporotic bone, we should not hesitate to use a cemented sleeve. So we can use a cemented sleeve, which is the smallest size. The next sleeve is an uncemented one, is a big jump, almost 2-3 sizes up. Exactly. So we should not hesitate to use a cemented sleeve. We can use a small stem, cemented stem, and use a cemented sleeve. Excellent results. Even in revision scenario, definitely cemented sleeves and cemented stems do well. So we should not hesitate to use that.
Even when you're using these rotating hinge implants, their femoral component, if you see, even the smallest one is quite bigger in most of the patient. So would you like to give some tips there?
Yeah, in the debut, even the smallest one is quite big. If you are using a femoral for a female, you have to ask specifically for the extra small. Normally they don't have it on table routinely, so you have to ask them routinely. So this is where your sleeve helps. Even in the femoral side, that is what everybody are in the literature also they are mentioning, that if you are using a rotating hinge, better to use a sleeve, both femur and tibia. And in a femur also, if you are any doubt, you can use the cemented sleeve. So once you use the sleeve, you are able to get away with that bigger implant. So that should not be a problem.
So that's a nice one. So can we have Rajesh to start on his next oration?
Can you see me?
Yeah, Rajesh, we can see you.
Okay, so I think my first brief is to speak on the lateral retinacular release and difference between inside and outside in technique. I think the inside out technique is easy to perform. The joint is already open for you, and from inside you go ahead and release it. However, in order to do that, you first have to cut the synovial layer, which means that there is a likelihood once you cut the synovial layer and the retinaculum that the extravasation of hematoma may occur. Anup, you are able to hear me, right?
Yeah, we can hear you.
So this leads to extravasation of the hematoma under the skin, which can discolorate the skin, thin skin in some of the rheumatoid or the other patients, tenting of the lateral skin, vascularity, the possibility of infection ingressing direct in continuity with the subacute hematoma into the joint. Whereas the outside in technique, which is what I use, although you need to raise the lateral skin flap, it's a very tiny one, and most of the time in the exposure you've already done that. The important thing is that it leaves behind the synovium layer intact. As you can see here, there is no extravasation of the blood, intra-articular blood that collects post-operatively, and therefore it is a safer thing to do. I started using this technique in 2000 and have modified it and have been using since for all my patients. We reported our technique in the clinical orthopedic and related research in consecutive about 1800 patients. We had done it in 200 patients. So it's a small incidence of doing a lateral retinacular release. It was 10% then. Currently, it is about 4 to 5% of the patients I do the lateral retinacular release. Now, the indication for release for me are based on the grading of the patellar tracking, which I describe in that article. And I do it after tourniquet release and using no thumb technique. And I grade them into 5 grades. The grade 1 is normal, where both the facets are touching the femoral prosthesis. Grade 1 is near normal, where the separation is only less than 2 millimeters. Today's case, which I'm going to show, has a grade 4 patellar tracking, which was preoperatively dislocated patella. The technique I do is in 3 steps, step 1, step 2, and step 3, and stop at each step if you got the sufficient release. And in 75% of the patients, you don't have to go to step 3, which actually preserves the lateral geniculate artery. We were to show our video at the American Academy this year, but it got canceled. However, they've put up the video on the Orthopedic Video Theater, and it is up there for you to see. Unfortunately, I can't show you here because it's a 10 minutes video, but it highlights not only the surgical technique, it highlights gives you pits and pitfalls and tricks to avoid them. So in summary, this technique is simple, stepwise, preserves the synovial lining in all the patients and maximizes the preservation of lateral superior geniculate artery. It is effective in all severity of maltracking and effective with all types of implants. Let's go on to the current case. It's a patient with valgus knee, 51-year-old female, severe right knee pain for 3 months, overall ongoing for long time, had 30-degree valgus deformity, opposite side little less, range of movement from 15-degree deformity to 115, some amount of extension leg, medial moderate instability. Now, this was the pre-op X-ray. The most important thing to note here is that you can't see the patella in front of the knee. Patella was sitting all the way laterally. And throughout the range of movement, that's where it stayed. This is the long leg X-ray, which I think must always be done any severe deformity, particularly all valgus patients. Here is a pre-operative video, standard severe valgus, partially correctable. Most important finding is I opened the joint through midline skin incision, idea of medial parapatellar. This is the VMO, right, sitting in the front, not on the medial side. And the patella was sitting here, right, laterally. So I proceeded with my medial parapatellar. And you can see here where the patella was articulating. This is where the trochlea is. The patella was articulating here. This is where it was articulating and staying there throughout the range of movement. Even in extension, was not falling back into the center. Flattened patella, standard cuts. So the steps were exposure, cuts using cast, trial reduction, soft tissue correction because there was valgus, posterior lateral capsule, posterior lateral corner, IT, and which I do a joint line cut from inside. I've gone through the multiple stab incisions, and I found in many other cases, you end up almost transecting it to get the good amount of correction. So I've gone back to cutting it transversely at the joint line through the joint itself. Now at the end of this, here in this patient, the residual valgus was still 12.5 degrees. And I decided then to do the lateral condylar osteotomy. And as Dr. Bria initially said, the chunk has to be pretty big sized so that you can have a purchase on it. This is the osteotomy done. After you've done all the trialing, etc., the fragment now needs to be moved and can be moved in two ways. You can move it distally and you can move it posteriorly. How much you should move depends on what correction you need, and computer navigation helps me in doing that. If you have only extension tightness, then you only need to shift it distally and trim the distal part, depending on how much you moved. If you also have a tightness inflection, you will need to move it distally and posteriorly, which is what I needed to do in this patient. Now, initially, I used to put 2 long screws, as we saw earlier in some of the cases. But what I've done, because I use PS joint most of the time, sometimes you find that the direction of the screw might hit your box. So I temporarily use the good strength wires and put them through the box to temporarily hold my osteotomy, which will then allow me to put 2 short screws in very good bone. So this is here, the osteotomy has been moved distally as much I needed based on the computer navigation, the wires to hold them first. And you can see on the navigation, now my correction is to about 1 degrees. And as mentioned earlier, valgus knees, I am happy to leave them within 2 degrees of valgus. I don't want to correct them into varus. Varus knees are different. I like to leave them in 1 degree of varus, the valgus, about 1 degree of valgus. And that is where you then fix your 2 screws. And you can see here that I've moved the osteotomy about 6 or 7 millimeters distally and 2 or 3 millimeters posteriorly to get the correction on both sides, in extension and inflection. Now what was remaining at the end of this is that my patella was still tracking laterally, and I needed to do the lateral retinacular release, which is what I did. stepwise release. Step 1, step 2, step 3, all are completed. Your synovial lining is left intact inside. And this is what I was discussing when we were talking about the valgus approach, that you have a synovium which is left intact inside, and you don't need to worry about the hematoma coming out or there is any decreased vascularity to the flap. This brought back this and the, of course, correct rotation of the femur that I did. That brought back the patella back into the position, but it was still, according to me, grade 1A tracking, or maybe almost falling to 2 if I remove that pressure from the thumb on that side. So I needed something more to track the patella correctly, and this is what I did. This is the VMO, which you all saw that it was very stretched out to begin with. I did a double breasting. Let's see if that video will work. Yeah, so you can see that this is the VMO, which was stretched out. I brought it over, not only proximally, all the way distally to the lower end of the patella, and double breasted to tighten the medial side, and that brought the patellar tracking to all the way grade 1. Double breasting, and here is the patient. You can see immediate post-op, the patella is now sitting right in the front. Good correction, that's the osteotomy. Patient, of course, mobilizing using a brace and a support. This is at 2 months. You can see that the osteotomy distal shift of about 6-7 millimeters. And this is at 2 months, patella sitting right in the front, right in the trochlea. And here is at 3 months, patient bending at this stage about 90 degrees, and I expect it to go a little bit more. But pre-op range was about 115 degrees, which is what I think I should get. Thank you very much for your attention.
Wonderful, Raj. So any questions from the panel?
Very good case, Rajesh.
Thanks.
Rajesh, can you just stop slide sharing so that the next speaker, Dr. Sanjeev Jain, can put his slides?
Yep.
Rajesh, I have 2 observations in these cases where you have a dislocated patella. There are 2 things. One is the release that you very rightly mentioned. The second is the rotation, correct rotation, increased rotation of the femoral component.
Yeah.
Do you routinely, I mean, in these difficult cases, do you increase the rotation, which probably is a far bigger help in some of my cases?
So I think there is a problem in increasing too much, but I agree with you that if anything, you want to have a slight more external rotation, not the internal rotation. However, the problem of doing too much external rotation is that the medial laxity in the flexion. So I don't overdo external rotation. I put it wherever it is. I think the best rotation based on the epicondyle and overall anatomy of the distal femur. And I rely on lateral retinacular release. I don't think there is any difficulty in doing that. And theoretically, yes, you cut the medial side of the joint, the retinaculum. You're now doing the lateral retinaculum as well. You can devascularize the patella. But if you look at the literature, in practical life, it is not that common. I preserve the lateral geniculate artery in significant number of patients because I do step 3 release only if it is really required. I do step 1, check whether I've come back, step 2, come back and check. But yes, I have had to do complete release and that's a small risk. However, even in those patients who have a decreased vascularity, it happens somewhere between 0 months to 12 months and the collaterals pick up and the vascularity increases and nothing really happens.
There's a question from the YouTube. Did you do your release after releasing the tunicate or keeping the tunicate on?
No, so always after, I expect that the question is about the lateral retinacular release.
Yes.
So it is always after tunicate release because you release the tunicate, the tether on the quadriceps is released and your tracking might become better and you may not need the release. So always check after releasing the tunicate. So my releases are always after tunicate release.
Rajesh,
okay.
I have a question for you to understand the technical aspect of your sliding osteotomy. You showed that you put those wires from the box cut that you do. So does that mean that you don't cement your, because you showed the definitive implant in place in this case, but does that mean that you don't cement them, or when you pass the wire before, what is the exact sequence?
So after you made your box cut and you're trial implants are in, you decide whether you're going to do the osteotomy. And you do your osteotomy. Now you put your wires. These are the high strength wires, the fiber mesh wires.
Yeah.
And leave them there. Now you put your final component, cement the component, and now you put your osteotomy where you want to put.
Okay.
Okay, and it's not a very strong construct. You do need screws. You definitely.
I understand. I just wanted to understand the sequence of how you put those wires and then.
Right.
Thank you.
There's a question from YouTube that the proximal tibia has extorsion and femur has intorsion in valgus knee. Is this measurable with CAS?
Sorry, say that again. Femur has external
proximal tibia extorsion and femur intorsion in a valgus knee. Can you measure it with CAS?
He's talking about torsion, probably external torsion and internal torsion.
I guess you can. On the femoral side, if you study the relationship of the 4 axes that you want to judge the rotation with, the epicondylar axis, Whiteside's line, the posterior condyles, and the tibial cut, you will see that the difference between all of them with the Whiteside's line is tremendous. Whiteside's line can go up to 40, 30 degrees in severe valgus compared to the other. But I think how much to go by that, I don't know. But that is an indication of external extortion on the femur. Now the intorsion on the tibia as a secondary effect, I'm not very sure that that's what happens. No. I think tibia is also in some amount of extortion.
External rotation,
yeah.
Okay.
So Rajesh,
last question on YouTube that what is your postoperative protocol after lateral epicondylar osteotomy?
So I think most of the time it is the same, except that I will give them a brace for a while and they might walk with a walker for initial, instead of 5-10 days, they would walk for about 3 or 4 weeks with the walker. But that is at the maximum. Your osteotomy needs to be very stable. It's not weight-bearing part of the osteotomy. And so there is basically no severe difference significant difference in the postoperative protocol.
Well, we can maybe discuss about your dislocation of the patella. It was a permanent dislocation. You balance your patella very well in the transverse plane.
Yes.
And the problem is that your extensor mechanism is too short. And I found that you can do pie crusting of the quadriceps tendon as described by Chitranawat, and then you will gain 15-20 degrees more flexion.
Yes, I think I considered that, but I did not, that VMO was already stretched. I did not want to weaken the quadriceps in this particular patient any further. And therefore I left it. I could judge on the table that my repair was significantly good till about 70, 80, 90 degrees. And I said, I will leave it at that, and I did not. But you're right. I think it's a great point.
Yeah.
We'll do take a needle and do a pie crusting of the extensor mechanism if you want to gain that 10-15 degrees. Excellent.
Wonderful.
Rajesh, just that this is a very important point. So what Jean-Louis has just pointed out, that pie crusting, I often had to do it even in our, not just valgus, but even in a varus knee. And what probably Jean-Louis, and correct me if I'm wrong, is referring to is the lateral border of the rectus. See, when you do a lateral retinacular release, that's a different structure. And as you go a bit higher up, is the lateral border of your rectus muscle, which is a bit laterally displaced, especially in a valgus knee. And when you bring it on top in the front, there is a tendency to pull, and that pie crusting becomes very useful. Although I understand in this particular case, Rajesh has explained why he solved the problem with a VMO overlap rather than pie crusting. But that's a very important point Jean-Louis has just pointed out to the audience and to all of us. Yeah, thank you.
Yeah.
So I think from your point, I did a lateral retinacular release. The step 3 is to release the lateral retinaculum all the way up on the lateral aspect of the vastus lateralis, and therefore that tether also is reduced.
Okay, fair enough. I understand.
Yeah, fair enough. Thanks, Rajesh. Thanks for a wonderful presentation. And with this, we move on to the next speaker, Dr. Sanjeev Jain, to start with this case.
So basically, thank you so much, Manuj, basically, a lot of overlaps in the talks, and I'm going to make it very simple when to use a constrained knee and a valgus situation. And as you know, the correction of deformity and establishment of the ligament balance is the crux in this, especially in this valgus knee. And then frontal deformity in the valgus, which has two objectives, but notably, it may be very difficult in a patient who's got a huge convex laxity on the medial side or deformity which is passing 20 degrees. Now, you can do certain techniques which has been talked and discussed by my other colleagues, by Patho string, lateral epicondyle osteotomy. But when these techniques are not able to balance the knee, then you may need to have a constrained prosthesis and maybe sometime the hinge prosthesis with significant bone loss and significant laxity, which has been talked by even the Rajkumar who has covered it. So very simple algorithm for grading of the valgus knee by Ranawat, which has been described: long back, less than 10 degree with MCL intact, considering the MCL attenuity, 10 to 20 degree grade 2, where the MCL is attenuated but firm on the endpoints. And the third one is more than 20 degree, where possibly it's severely attenuated MCL. Depending upon this, you possibly will decide about the level of constraint in the valgus knee. And this is how it has been described by the diagrams. Now, if MCL is intact, it's very simple. You follow all the principles and you can get away with a simple poly insert, whether you're using PS design or CI design. When MCL is elongated and it is less than possibly the 20 degree, possibly you will need a constrained poly for a sufficient stability. But when the MCL is completely absent, or as the Rajkumar has shown, the cases probably you will need a more constrained process. This is probably of a hinge variety. So these are the three grades where you can use the three different kind of constraint, if at all is needed, on the table. But mind you that the computer navigation, if those who use it definitely gives you then excellent titration of the release, excellent gradual titration of the release, and balancing of this ligament. And there you can also decide about the type of implant which you are going to use it. But always it's a dictum in the valgus knee. Even if you're doing a simplest valgus knee, you should keep a backup of a constrained knee in your armamentarium. So what is the constraint process? It's basically an insert. The normally the tibial post is there, but in a constraint prosthesis, it's a tall post, and naturally it's a thicker post, and it could be stamped or unstamped, but naturally it has been told in the literature that to always put in a stamp. So it's a diagram here. If you can see here, this is your normal post, okay, which is standard total knee post in PS design, which does not provide any stability to median and lateral side. But in a constrained implant, the post is quite thick and also the wide. So it's tall and the wide, and this will provide you the excellent stability needed, which I'll tell you the indication. These implant, whenever it's been used, should be supplemented with a stem on both the side. If used in defects are on both the side, then probably they will distribute or share the loading forces correctly. So this is how these constraint inserts looks like for a younger people. Please remember there are varieties of implants are available in the industry, and there are some implant where you can use only the primary PS joint without having an extra bone cut. There are some implant where if you have to use like TC3, you'll have to use even the little more bone cut and maybe a little more wider one. But in some company, they use something called a PS plus. The femoral component remains the same, only the constraint or this thing can be accommodated in the same femoral component, which is wise to use in this kind of situation. There are paper which says there are predictive preoperative parameter which can influence your constraint design, and which is if you have less than 5 degrees of residual frontal laxity, an extension of each compartment, or if you have a tibiofemoral gap difference not in excess of 3 degrees between flexion and extension, there you can use an constraint implant. So it's a convex medial side laxity which would decide, especially using of a constraint implant. So it's a grade 1, case number 1, which is simple case, a grade 1 valgus deformity, where you can get away with either the PS knee or you can get away with the CR knee. There's no issue about it. But a patient like this, when you have a less than 20-degree deformity, you have a defects. I'm sure that everybody has seen that what is the bone cut should be there, how much tibial cut has to be there in this kind of situation. You should be using to balance knee constraint implant, which is a simple constraint implant which can use it. And in this situation, you have to be also careful in deciding about the rotation, which Ronan has talked about it. And when you're using a cast, I'm sure when you're using this kind of implant, you can always decide about the rotation with the cast, or the Ronan has described, he talked about the rotation, how to take care of the hypoplastic lateral femoral condyle and the femoral component rotation. Even Rajesh was talking about it. You can judge and place your implant. So always these constraint implant, when there are bone defects, has to be supplemented by the stem on both the sides. So this is how you decide about using a constraint implant in a valgus knee. The cases like this, very severe valgus deformity, or the cases like shown by Rajkumar, probably would need even the higher level of constraint to even hinge prosthesis, which has been already discussed, and which I may not, I should not cover it up because there's a lot of discussion happen on this. There are papers which says what are the clinical outcomes between these kind of two prostheses, comparing CCK and primary PS up to a couple of years. There is no difference. We have to see the long-term data. There are prostheses which paper which are also talking about the difference between the condylar constraint design and rotating hinge study, which is also been there in the paper, and that all shows that we need to, wherever you're using a more higher constraint variety, you need to stem it, because there are forces which is going to transmit on the bone implant interface, which will prevent the loosening if you use the stem. So definitely there is a selective use of constraint design in valgus knee on a TKR, which has got a significant role. You have to be careful and always keep full inventory. Use the stem, which is absolutely necessary, and other procedures, especially to deal with the bone loss, maintain rotation, proper patellar tracking. In a severe case, along with using constraint implant, is very important to give an excellent result. Thank you so much.
Thanks, Sanjeev. And Bharat, in the meanwhile, can you just start putting your slides on? So by the time Subhanshu brings a question slots on the YouTube, I have a small question from you, Sanjeev. Now, in all these severe valgus cases, we have a lot of distal femoral metaphyseal remodeling. What are the tips you would like to give to the audience listening to this? What is the way they can manage their distal metaphyseal femoral remodeling?
So we have talked about it. First of all, that the two things which can happen is the rotation correction, which we need to think about it very seriously, and where you have to see that remodeling is happening when the rotation distal femoral lateral distal femoral condyle, which is deficit. Probably you have to give more of the external rotation to prevent the internal rotation of the component. That's one. Second thing we have also talked about is to cutting the valgus angle, which should not be too much of valgus. It should be around between 3 to 5 degrees of valgus, and which will take care of the issues. Third thing, when you're doing a rotation correct, you need to also be careful about basically of preventing the notching on the anterior surface.
Okay, there's a question from Dr. Smarajit Patnaik. Dr. Jain, how do you approach your medial side exposure and proximal tibial cut in a valgus knee to reduce your constraint, especially in grade 2?
Pardon, sorry. There's some
approach and proximal tibial cut.
The approach has a no issue with the same medial parapatellar approach. So you can get away with the medial parapatellar approach.
Any need of tibial tuberosity osteotomy, as these cases have intrapatellar problems also? Question to Dr. Maniar. Is Dr. Maniar on?
Yes, I can hear you. Tell me again the question, please.
what is your role of tibial tubercle osteotomy? Because you had a difficult, patellar maltracking, there might be infrapatellar problems.
Yes, well, I think that for me, that probably is the only indication that I may have to do a tibial tubercle osteotomy. But otherwise, for all my revisions or difficult exposures, I use quadriceps snip or extensive, releases in the gutter to get my exposure. So I don't do tibial tubercle osteotomy for exposure purposes, but for a patellar maltracking, you may need to do when you have such a severe patellar maltracking as grade 4. Any up to 3, I am very certain that you should be able to reorientate it by your femoral rotation and by lateral retinacular release. And even in grade 4 with complete dislocation, in most of the cases, I've been able to do this.
One more question to you, that is there any plano valgus fit, that in those cases, do you change your implant alignment to accommodate foot deformity?
I think it's a very good question, but I don't have a very concrete understanding of this at the moment, but I would definitely look at it. And there are some patients, I send them to my foot colleague for them to evaluate first. At the moment, the consensus is that if that foot deformity is correctable, I would just go ahead and do my normal orientation to the center of the ankle, or maybe a little bit more towards the lateral side, that means in valgus, and then see over the next 6 months whether they accommodate or correct it out or not. If they don't, they would need some correction if it is symptomatic. If their deformity at the plano valgus is so severe and fixed, and patient actually has symptoms in the ankle, I would tell them that either you need that corrected first, or you may need the second operation after having done the knee.
True, Rajesh. And I think there is
I agree with you that, I agree with you that usually doesn't require any correction for the alignment. But if your tibial is posterior is non-functional and it's or is a fixed planovalgus deformity, at least I would recommend not to use, CR knees in these cases. PS knees are preferable.
Shubhranshu, regarding the tibial tubercle osteotomy, one of the best indication for tibial tubercle osteotomy is the stiff knees, but one must ensure that the bone is not very osteoporotic. So we have done the tibial tubercle osteotomy in a very large number of cases, but especially the stiff knees. The big advantage of tibial tubercle osteotomy is that you can proximalize, you can lengthen the quadriceps mechanism by shifting the tibial tubercle proximally.
What is the experience of Dr. Brad on the tibial tubercle osteotomy?
I think he has done a lot.
And what is the indication?
Dr. Brad, you are on? Yeah.
In the past, I think I tend to do less and less. I think in revision, it may be helpful. And in the case of dislocated patella, it may be useful. I have one case where it was really too much lateral and we had to medialize it. But I don't like complication with tibial tubercle osteotomy, as you all do.
Okay. I think we move on to the next last case of Bharat Bhai, the most scared thing what we talk about, lateral popliteal palsy. Correct,
Thank you.
Bharat Bhai? Yeah.
Thank you. Can you hear me, gentlemen?
Yes. Yes.
So we have just about covered almost everything that should be done when we deal with valgus knees, and I think the audience would have been able to gather a very comprehensive understanding of how to approach valgus knee problems. As we have just seen, that it is more challenging than varus because the number of distinct structures which get involved in contractures as compared to varus are far more distinct structures. The presence of the lateral popliteal nerve, and because the incidence is less as compared to varus, so familiarity takes time to build up. And several authors, see, all my colleagues just now on the panel have shown you all the nuances of the techniques. And what I suggest I'll just go through is that how controversial this particular topic has been will be brought out by the different sequence of releases as recommended by giants of this field over the years. Insol. In fact, if you go back to Insol's original paper on this, it says start with the release of lateral collateral ligament, which today would be anathema, and then popliteus tendon. Look at how amazingly the compass has turned, and we would never think about these two as being the structures to be released, and yet nobody less than Insol himself had started off with this. And look at this, ITB only if severe external rotation deformity. So going back on these literature and reviewing it just lets us understand how complex this area of work was, and how a complete reversal of thoughts have taken place as experience built up over the years. You had Krakow, once again, LCL as the first structure to be released, and then go on to the secondary stabilizers. You had Laskin, who started with the ITB first, but even he suggested popliteus tendon as your second structure, and then going further down to LCL and LG. You had Buechel, who had a lateral parapatellar approach, which we discussed earlier, as his first step for valgus knee releases. Then you had your ITB, and then the LCL and POP-T. And lastly, he went as far as to say fibular head resection. And then you came along, we had Ranawat coming up with his concept of releasing. And that is probably, in my opinion, the most widely adopted in the modern day sense, where he said ITB as a pie crusting technique. Even Ranawat does mention popliteus tendon, LCL, and posterior capsule, although now the sequence has changed, that it is ITB, posterior lateral capsule, and then one would go to these other things. In my own personal methodology, I have adopted this. ITB, I firmly believe, is probably the most important influencer in this because of its dynamic nature with a muscle pulling on that structure. I don't have any reservations in using the POP-T, although now, if I want to do it, I'll go to the POP-T only after I have done the posterior lateral corner and lateral release, and if after that it is required. LCL release, not as the ligament itself, but the sliding lateral condylar osteotomy is what I would now adopt. Although in my practice, it's very, very rare that I have to do a sliding lateral condylar osteotomy. So what is the case example that I want to bring home? Despite the best of efforts, and this is a case which I had to handle early on in my career, which is roughly about now, I would say 17 years back is when I had handled this case. She was a school teacher, a burnt out rheumatoid with extremely rigid knees, very limited mobility over the last few years. And when she came to me, this is how she looked. On the right side, it was a grade 3 deformity. On the left side, it was a grade 2, just about to enter the grade 3, but both sides being extremely rigid. The bones were very osteoporotic. And this is what the x-rays looked like. There was some stretching of the medial collateral, but still, I mean, it was not something for which I would have thought about a constrained implant, certainly not in those days. In any case, 17, 18 years back, budget as well as availability were issues. So what is the lesson that I wanted to bring home to the younger generation here? I did everything that the surgeons, I mean, our panelists have just described in terms of the release, but I was a bit afraid in doing the lateral release in that sense that I was afraid that I might bring that knee open laterally, destabilize that knee. And therefore I was a bit conservative. In other words, this was a lateral view. When I finished my surgical action here, see here, it all looks good. But what I realized later on was that there was still tension on this lateral side. The iliotibial band and the especially, I think the iliotibial band was extremely tense. On the first side, it was a bilateral knee. 7 days, and in those days, I used to keep patients for 10 days. I did not do in quick succession. I would do the second knee only after I was happy with the first knee not being running into any trouble. And on the 7th day, the woman, while she was walking, she just told me that I think I heard a cracking thing, and nothing more than that, hardly any pain, anything. In fact, I took this x-ray after 24 hours or a bit more when she kept on saying, I can't walk well anymore. And when I took the x-ray, I realized that there was this fracture oblique or whatever medium oblique fracture that I saw here. And this was with an extremely low energy trauma. I think what had happened was that this lateral side tension, which I'm trying to show with the cursor, that tight tension here had actually made the you could tell, and there was someone would say that it was notching, but the fracture plane is where I wanted to bring home the point, because exactly the same thing. This happened. I had no option. In those days, it was a minimally displaced thing, and I chose to treat it just with a plaster cast. Same thing happened on the other side when I did a few days later, 15 days or so later. And here, exactly the same thing, that it just gave way on the 7th or 8th day while walking. And again, here also, it was a long oblique sort of a fracture, like going from here to here. These things that you see are because I treated it conservatively just by, plaster cast, and there was some displacement between the two fragments. The notching that you see, or the impression that you get of notching, was not what it was. More importantly, gentlemen, both the sides had developed peroneal nerve palsies, both sides. And these were despite my not doing any aggressive cutting on that posterior lateral corner that we just heard. It was just correcting, but it was an extremely rigid knee, and correcting those deformities in itself had caused peroneal nerve paresis. The good news was that over a period of time, and I think it was about 3 to 4 months, that the peroneal nerves had recovered completely, the fractures had healed, and I could get a fairly good, alignment correction as well as functional results of this case. What is the message? It's a very simple message. The message that I wanted to bring home was, in extremely osteoporotic bone, even if you have a visual alignment on table, if you have not released the lateral side pull and tension of the lateral tight tissues, especially the iliotibial tract, you might end up getting this stress fracture, as I call it, or a fatigue fracture of that osteoporotic bone. And once in a while, you will have your peroneal nerve paresis. As someone else earlier pointed out, it's the rate reported in the literature is almost 3 to 4%. Although I think as time has passed by, and as we have heard, as we understood this pathology much better, the rate of peroneal nerve palsies have decreased dramatically, because I'm sure none of my colleagues on the panel would face this level of peroneal nerve palsy anymore. But for the audience, those who are still earlier on in their career graph, if you have a peroneal nerve palsy without having had cut it, just because of the correction and stretch, the good news is that they do recover. And I don't think you need to do anything more. The literature does have some preemptive solutions in the form of either peroneal nerve anterior transposition or resection of the fibular head or neck to prevent the stretch. I have never done it. I would be quite interested in knowing whether my more experienced colleagues like Jean-Louis or my other peers here have had any reason to adopt those procedures as part of their preemptive step in a valgus knee. I have never done it. Luckily, as time passed by, I realized that as long as you do an appropriate release on the lateral side, that fracture thing has never again bothered me. And I have not had to worry about peroneal nerve palsies, because I do a very graded type of a correction from now on. If it is a correctable knee, there's never a problem, because all the soft tissues are also equally capable of accommodating a straight limb. The real worry would be when you have a very rigid knee, where the soft tissues on the concave side have not had a chance to accommodate that alignment and that stretch. And then you might have an injury in continuity, but it usually recovers. So to conclude, the valgus knee in total knee arthroplasty is more challenging than the varus knee. However, given adequate knowledge and understanding, and if you give the right attention, it can deliver satisfactory results. It's a simple message. It's a quick one, but I think it is something which might help a young surgeon if he runs into this sort of a problem. All the other aspects have been very comprehensively covered by my colleagues earlier. Thanks.
Thanks, Bharat. Now, before we start on, one is what is the message you would like to give to younger colleagues? You move out of the OR. Unfortunately, 3 hours after surgery, you see that the patient is probably having a peroneal nerve palsy. What are the things you would do at that stage, and what is the message for young listeners?
So if you are confident that you have not breached that posterolateral corner and in that the Bermuda Triangle, the danger triangle, if you have not gone deep in there, if you are 100% confident, then I wouldn't do much. At the most, I might do a nerve conduction study to see, or a MRI, presuming that the metallic components that we have used are MRI compatible. MRI might be useful, or at the most, as I said, a nerve conduction study to see if it's an injury in continuity. But short of that, and giving them a foot drop splint, I would continue with and reassure the patient that it will recover in due course of time. In nerve injuries in continuity do recover. They do take 3 to 4 months at least, before they will show some signs of recovery. But once they show some signs of recovery, usually they go on to a full recovery. So that would be my message, that don't get too panicky. However, if you have reason to doubt that you might have gone a bit deep and cut the nerve trunk itself, then maybe wisdom would be in doing an exploratory thing and call in an expert who can do appropriate nerve repairs.
Would you bend your knees and take off the dressings as a
Yes,
baseline?
that's a very, very good point you have brought in. You are very right. I wouldn't keep that knee in extension. I would keep it in some flexion to relieve that tension off from those knees. That's an extremely important point. I agree with you.
In fact, as a general rule, I would suggest that for all valgus knees, it's probably safer to keep them in a flexed position for the first 24 hours.
Yeah, why not? I agree with Ronan. That would be a good idea as well. From this particular case, that's something that I would certainly recommend to anyone who's a bit worried. Keeping them in flexion for 24, 48 hours is not going to cause any harm at all, and it might prevent an unnecessary problem with the nerve.
Yeah, Rajesh, look up your question.
Yeah, I think two other points that we need to keep in mind. One is that if you're injecting a cocktail around the knee, make sure that you don't inject in the lateral, where the common peroneal nerve is. So I don't inject it because it has been reported that you can get a temporary palsy because of the injection in that area. Second is, I think Rajkumar brought it up at one of the webinars, that your lateral retractor, the spike that you put, you need to be very careful where you put the spike, particularly how long the spike tip is and whether the patient is very high BMI. So those are the two other points.
Yeah.
The question I wanted to ask Bharat was, Bharat, did you have the palsy after the post-op or did you have it after the fracture?
No, I had it immediately post-op. The fracture occurred 7 or 8 days later, while she was just routine mobilizing. In those days, I used to keep these patients in the hospital for 10 days, actually, 10, 12 days, till I was sure no infection is there. You realize these are the early days of arthroplasty that you and I.
It is something very surprising has happened. Similar sort of fracture on both sides. I still, explain.
I agree with you. It was one of those cases. That's why I brought it up, because it was a very unusual thing.
Yes.
And both the time it was extremely low energy trauma. It just click. The patient just felt some cracking type of experience. Without, in fact, the first time around, I didn't explore with an X-ray because the patient didn't give any serious signs of pain as well, But there's something that I thought maybe I could share and it could be useful to someone.
Okay, Bharat bhai. Yeah, there are one important point is that usually correctable deformities do not get postoperative nerve palsy. It is the tight knees with flexion deformities. They get the nerve palsy. There are chances of that they may get a nerve palsy post-operatively. That is one important point.
Yes.
And in addition to that, spikes, periarticular injections. Third thing is that, as I mentioned earlier, that the triangle between the cut surface of the tibia, popliteus, and posterior border of the IT band, that is the danger zone. One should not do a lot of, very deep pie crusting of the nerve there. But most of them are usually stretch injuries, due to the correction, inadequate release and stretch injuries of the popliteal nerve.
Absolutely. Yeah.
One more point I'd like to add upon all the points which has been discussed now. The most commonly and the peroneal palsy happens is because of the bigger inserts. Some surgeons, they try to do release and they are not able. Suddenly they feel they take more bone cuts and then they suddenly feel the joint is becomes so much loose, and they try to keep on adding the insert sizes. And the more the thickness of the insert becomes, the knee becomes tight and then facile. That is also one big reason for the peroneal nerve palsy. So, and
Very good
one more
point, Rajkumar. Very good point. I agree with you.
yeah, and one more point is when the surgeon sees the postoperatively immediately peroneal palsy, it is better to keep the knee in flexion and also avoid the CPMs. Many of us give CPMs immediately, so better to avoid CPMs. And also one more thing, preoperatively discuss with the anesthetist and ask them not to put epidurals in a gross valgus situations where you want to assess the patient immediately after the surgery. Better to not give epidurals and add the pumps. Pain management pumps, which gives continuous numbness of the foot. So avoid that, and also to avoid steroid in the adductor canal blocks and everywhere in a valgus knees. The anesthetist might add a lot of steroids everywhere in the blocks they give. So better to avoid all those steroids, epidurals, keep the knee in flexion, and avoid CPMs in the postoperative period.
Great points.
So, Bharat bhai, one more point. As we talk in the hips, we always take and form the consent for the patient or limb length inequality. Whenever we are doing this kind of knees or severe deformed valgus knee, I think it's very important that patient also must know preoperatively there are chances going to be a peroneal palsy, because that keeps on troubling them and that keeps on troubling everybody. We know it's going to recover, but I think that's become very important sometime the point medico-legally as well.
I have a comment to make. Is this two comments, in fact. Peroneal nerve palsy, is it more common if we have medial laxity, which we are trying to address by over-lengthening the lateral structures?
Yeah.
That's one point. Yeah. So is there any role of medial tightening rather than over-lengthening beyond a particular polyethylene thickness? That is one we should consider. Second, if you do a lengthening through the epicondylar osteotomy or a partial lateral condylar, since you're not lengthening at the level of the joint, there are reports in literature saying that possibility of peroneal nerve injury could be less, because if you do a release at the level of the joint and stretch it there, or you do it through the bone and get the tissue down, the risk of peroneal nerve injury could be theoretically lesser. So I have no evidence on that, but there are a couple of reports on the role of partial lateral condylar. So I would like opinion of the house on that.
So Kiran, if I could respond on that, the first point you made about that putting a thicker insert to try and compensate for a lax medial side, I think that is definitely a very important, or a plausible cause of a peroneal nerve stretch injury. The other point you made is a bit difficult to comment on because we are talking about some anatomical understanding of how a stretch on the peroneal nerve could be generated or not generated. So I won't comment on it because I'm not too clear about it myself. But the first one, I think you are very right.
Third point is you must extend the hip and flex the knee. So it's a good idea to put the patient in a lateral position, because if you just flex the knee, the hip also gets flexed inadvertently and then the nerve can get stretched. So we found that whenever you have peroneal nerve palsy, you take the patient into lateral position and then flex the knee after taking off all the tight discs. So that's another point I want.
One last question from the YouTube by Dr. Ankur Singhal. What is the exact distance of common peroneal nerve with posterolateral capsule, and also
2 mm. 2 mm.
When you do posterolateral corner release in flexion in valgus knee, and if not, then why?
It's on in extension, it is 2 mm from the outer thickness of the posterolateral capsule. The average distance is 2 mm. That is why you have to be careful.
I mean, it's supposed shown to vary from 2 to 4 mm. And
exactly.
Actually, the thing is that when you're doing your release that side, it's very important that your assistant does not put a finger inadvertently at the back, because that can actually bring it forward. He might think that he's helping you, but actually he's making the condition worse. So when you're doing a posterolateral corner release, it's very important to be aware of the tip of your diathermy or your knife. So it's very, very, and as Bharat bhai said, 3 mm and 2 mm is really nothing.
You're very right.
Okay, I think we have to wind up now. We have extended much beyond our time limit. Let me, on behalf of Indian Arthroplasty Association, first thank Dr. Manoj Wadhwa for moderating the session so nicely. And still there are almost more than 90 participants there in the YouTube. I extend my heartfelt gratitude to Dr. Brad, who is sitting from beginning till end from France itself to contribute towards this webinar. Dr. Brad, thank you very much. And all the faculty, dear friends, thanks for all your contribution. It was an excellent exposition from beginning till end, starting from the planning till the complex cases and, how to plan it and how to execute the plan. We'll continue with the webinars, dear friends. You please log into the indianarthroplastyAssociation.com and be a member of this association. And you can continue watching this in YouTube, this webinar, today's webinar. And again, we'll continue next week, taking up some hip issues, maybe cementing of the hip or any other issue. We'll get back to you. And have a nice time. Stay home, stay safe, and stay healthy. Thank you all. Now
Thank you. Thank you, everyone. Have a safe time ahead.
Bye-bye.
Thank you.